Is it dorsal somewhere up?
No, this is parietal lobes. Parietal lobes.
It involves the sinus?
Yes, in both sides. Sinus, yes. Totally occluded sinus.
Okay.
I will reject this sinus.
Second part of the sagittal sinus, yeah?
Yeah, second part, yes.
It could be difficult sometimes, really.
Yeah.
Okay.
Good morning, everyone.
Glad you're here.
Yeah, good morning. Nice to see you all. Liu, Professor Duboy, Professor Goto, Professor Omer Hodzic. Good morning. I'm working today, so maybe I'm gonna be on and off. But anyway, you know how it goes with emergency center. So, hey, hello, Sachin.
Hi, hello, Adi. How are you?
Good morning, yeah, or good afternoon. Okay, it's 8 o'clock. We are still waiting for the others, and I don't see Professor Kato yet here.
Yes,
we can make we can wait for a couple of more minutes. So start.
後藤先生、ありがとうございます。
ありがとうございます。
先生も忙しそうですね。いつもありがとうございます。Hi, Rahim, how are you?
Morning.
Hi, good afternoon.
Good to see you
Japan
again.
is 3 p.m. So maybe good morning. Hi, Andrew, how are you?
It's fine. Good morning,
I'm
Professor
fine.
Kato.
I'm very much looking for your lecture. Sachin, how are you?
I'm fine, Professor. Nice to see you.
Okay, nice to see you again.
Yes.
Dr. Kabulo, are you ready? Kabulo
Yes,
先生。
Professor.
はい、はい、大丈夫ですか？はい。
はい。
I taught him several Japanese words, so every day they are practicing.
Yeah, of course.
はい、はい、
はい。
大丈夫。はい。
はい。
ありがとうございます。So I think it's already 3 o'clock, so maybe should we start? Ibrahim, how do you think?
はい。
So
So
just
shall we start? Bro?
Yes, hand over to moderators, please.
So good morning, good afternoon, and good evening to all the friends, the delegates, the participants, and speakers for today's session. This is an interesting and unique session today we're having because it's a collaboration of 3 different societies. It's the collaboration of, it's a tripartite collaboration of the ACNS, Asian Congress of Neurological Surgeons, the Young CAANS, that is the Young Neurosurgeon Forum of Continental Association of Africa, and the Neurosurgical Association of Bosnia and Herzegovina. So it's an interesting webinar today because we have friends from different continents. So let's start. So before we start, just tell you that the host for today's session is Professor Ibrahim Omer Zorik from Bosnia and Herzegovina, our president of ACNS, Professor Yoko Kato, and the chair of Young CAANS, that is Dr. Renkubailo Tango. The moderator along with me is Dr. Adi from Bosnia and Herzegovina, and Dr. Kabulo, who is the co-chair of Young CAANS Forum, and myself, Dr. Sachin. So we have various speakers from different continents, and the chief discussant for today's session is Professor Abuzer Gungor, who is the director of microsurgical neuroanatomy laboratory at the Yeditepe University, neurosurgery specialist at Istanbul, Turkey, and Professor Maurizio Ikongei, who is the full professor and chairman at the Department of Neurosurgery and director of residency training program in neurosurgery at University of Politeca delle Marche. So let's start today's session, and as the tradition, we'll have the opening welcome speeches from our host. I would request Professor Yoko Kato to say some encouraging words for the young neurosurgeon.
Hi, hi everyone. Thank you very much for joining our very unique, the three continents, the webinar, I think. So we are very much looking for your all lectures, and maybe maybe some due to the local situation, I think sometimes the topics will be a bit different. So we are very much proud all of you. So let's start.
Thank you, Prof. Thank you, Prof. I would request Professor Ibrahim to say a few welcome words, and then we'll start. Professor Ibrahim.
Good morning, everybody. I'm really happy to see you all here again. And we are proud to collect the people from actually 4 continents, even North America. And that will be, I hope, interesting and useful meeting for young surgeons, and also to remind ourselves for seniors. We have interesting program, and I would like to thank you, Professor Kato, and her team. She's always help us to organize this. Sakin and Dr. Liu and all the people, Kabulo, thank you, Adi, for organizing that meeting. Of course, there will be some discussions. I hope the comments during the session from Professor Kato, Goto, and all the people here. We have very different and interesting program today. Not so many lectures, but we have the lectures from the spine, from the cerebrovascular and tumor surgery, so endoscopy also, and endovascular treatment. So I think so that even the pediatrics, so I hope that everybody could find something for him. Also, I believe that lecture will be actually accommodated for the younger guys. So mostly we will not go so in deep to very, very tricky and difficult cases, but to show how to solve the problems, even from the basic to the upper level. So I hope you will all enjoy, and let's start with other speakers. And
thank you very much, Professor Ibrahim. So before we kickstart, I would request the chair of Young CAANS, Dr. Nkubailo Tango. Are you there, Tango?
Yes, I am. Thank you so much, session. This is very exciting. And this type of webinar creates an educational system where we're globally all learning from each other and drawing from each other's strengths, and also seeing the unique neurosurgical conditions that we're treating in all our regions. So it's very exciting, and I look forward to all of us learning together. Thank you for the invitation.
Thank you. Thank you. Nice to see you. Thank you very much. So before we start, as I said, we have many speakers. I would request every speaker has got 15 minutes so that I request them to make sure that their presentation is for 15 minutes, so that we can give more time for the discussion. And since there are many speakers, I request all the participants to put their questions in the Q&A box or in the chat box. So maybe we can pick up maximum 1 or 2 questions after the presentation and have a small discussion. So let's start. I would request my co-moderator, Dr. Adi, to kindly introduce our next speaker and the title of his talk. Dr. Adi.
Thank you, Dr. Sachin, and my other co-moderators. Okay, we can start. The first speaker is Professor Andrei Dubovoi with the lecture Complications of Cerebral Bypass Surgery. So please, Professor Dubovoi, you may proceed.
Do you see my screen?
Yes, you can see.
Yes? Yeah, okay, thank you. Good morning all, good afternoon, dear participants, dear friends. Today I will tell you about complications in cerebral bypass surgery. Unfortunately, complications can occur not only in surgeons with little experience, but also inexperienced hands. In my practice, I had a lot of bypasses, high flow, low flow, intracranial bypasses, but unfortunately, I also have complications of this surgery. Not so many, but I have it. For simplifying of understanding, I have divided all complications by 6 different groups. First, this is problems with wound healing. For example, skin flap necrosis. Next, occlusion of the bypass. Next, hemorrhagic complications and others, ischemic complications. Other group, incorrect selection of the bypass type. And problems with wound tightness. For example, CSF leakage and CSF pillows. Look at this slide. According to different authors, the frequency of skin flap problems after harvesting of the single branch of STA can reach 30%. After harvesting of the both STA branches, can reach 50%. A very high percentage of skin necrosis. Look at this. You can see skin necrosis. It appears after harvesting of both STA branches because of skin flap devascularization. Sometimes it appears after harvesting only single STA branch. If the patient has only single STA branch, you can see one STA branch, no dividing on two branches. To avoid these complications, it is necessary to perform a skin incision along the branch. For example, along the parietal branch of STA in case of performing arcuate skin incision. If it is possible, harvest only one branch of STA and keep another one branch. And always suture the bed of the donor after taking artery. Treatment is very difficult. First option, in simple cases, excision of the edges of the wound and tightening of the secondary sutures. Sometimes it needs to remove of the underlying bone flap to reduce pressure to the skin and to make a contact with underlaid soft tissues. In difficult cases, it needs to closure of the skin defect with displaced skin flaps. And in very difficult cases, it needs to skin transplantation, as you see at this slide. Attempts at healing by secondary intention are usually unsuccessful. You can see failure of skin sutures as a result of marginal necrosis of the skin flap. To prevent this complication, it needs to create a large skin flap, including as many feeding arteries as possible. You can see small feeding arteries, posterior auricular artery, including into this skin flap. Sewing up the bed of the artery taken from the skin flap. You can see the bed after taking artery. This bed sewed. And performing EC-IC bypass from a linear incision, if it's possible. You can see mini approach along the parietal branch of STA. You can see STA before harvesting, after skin incision. The length of skin incision is around 4 centimeters, and the diameter of the craniotomy not bigger than 2 centimeters. Next, occlusion of the bypass. You can see the case of occlusion, the STA-MCA bypass, parietal branch. It occurs in cases of technical errors in creation of the bypass, as well as in case of insensitivity to pre-surgical antiplatelet therapy. To prevent this complication, it is necessary to avoid technical errors in creating of the bypass. It's also necessary to perform a platelet aggregation test before surgery, which shows the effect of antiplatelet agents. You can see bypass thrombosis lead to simultaneous thrombosis of the recipient M3 segment of the MCA, and you can see ischemical focus in MCA area. What about antiplatelet therapy? 5-7 days before bypass surgery, the patient should start taking aspirin 100 mg per day. On the day of surgery, a platelet aggregation test with reinducers is performed on the patient. You can see the platelet aggregation test and SP test by arachidonic acid. The reference values need to be less than 30 units. In this patient, 20 units. He is ready for bypass surgery. And after surgery, patient should continue taking aspirin for at least 3 months after surgery. And in cases of atherosclerotic intracranial or extracranial occlusion, for life. Next kind of complication is a hemorrhagic complication. You can see CT of patients with hemorrhagic complication. This is intraparenchymal hematoma located in temporal lobe. This hematoma from the side branches of the bypass, in this case from radial artery graft. In cases of inadequate hemostasis from the trunk of the harvested artery, you can see this complication. To avoid this complication, it is necessary to carefully coagulate these side branches extending from the graft or harvesting artery. So you can see this short video. Less commonly, bleeding occurs from anastomosis zone. You can see a small short video after making bypass. You can see small bleeding from the anastomosis zone. To avoid this complication, it is necessary to check the tightness of anastomosis by increasing blood pressure around 20% from initial level. Next, you can see big saccular fusiform aneurysm located in M1 segment of the right MCA. Our treatment strategy is to create maxillary artery to MCA middle flow bypass using radial artery graft. Then perform proximal occlusion of the MCA just before aneurysm. We perform this stage and we perform middle flow bypass and perform occlusion, proximal occlusion of the MCA. After performing bypass and the proximal occlusion, the patient was okay. But 2 days later, the aneurysm was partially thrombosed. You can see the reduced cavity of aneurysm, only distal part. And unfortunately, the patient had ischemia in territory of the lateral lenticular striate artery due to its occlusion. Not every time this complication, but sometimes if you have small lenticular striate arteries arising from the aneurysmal dome. In cases of atherosclerotic occlusion, before surgery, you need to study the native supraorbital EC-IC anastomosis. You can see the native anastomosis between STA and between ophthalmic artery. If you disconnect this anastomosis, the patient may have ischemic complications. Next kind ischemic complications due to incorrect selection of the bypass type. You can see CT angio of the young patient with big cavernous aneurysm. Our treatment strategy was to perform middle flow bypass between internal maxillary artery and MCA, and then proximal endovascular occlusion of the cervical part of ICA. You can see DSA after making bypass. You can see functioning bypass. You can see MCA M1 segment, M2 segments, ACA, ICA, and you can see DSA after ICA occlusion on the cervical level. You cannot see ICA, you cannot see ACA, you cannot see proximal part of MCA. You can see only distal part of MCA after bypass. This is bypass. This is internal maxillary artery. What happened? After awakening, the patient had hemiparesis, and after performing MRI, we see big ischemical focuses located in deep area and in the cortical area of the MCA territory. We study the angiograms, and we can see the thrombus inside the proximal part of M1 segment. This thrombus thrombus formation after the competing of the two blood flows. One blood flow from the opposite side through the ACOM. You can see ACOM, opposite side. You can see a big diameter of the ACOM, around 3.5 millimeter, and another side from shunt. You have another flow. You have two flows, and competing two flows in area of the ICA bifurcation and thrombus formation, and patient has a big problem. And last, the problem of the tightness lead to CSF leakage, sometimes meningitis, and subcutaneous CFS pillows. In cases of marginal necrosis and failure of the postoperative sutures, most methods for stopping CFS leakage can be unsuccessful. To prevent of this complication, you need to careful close of the dura after making bypass. You can see bypass, and you can see the closing dura using tachocomb. In this case, you can use outer fat tissue or fibrin glue, or combination of outer fat tissue with fibrin glue to hermetization. In conclusion, you should carefully examine the function of the communicating arteries, PCOMs and ACOM, and direction of the blood flow through the arteries. Carefully perform all surgical stages to avoid complications. Choice of the donor artery and type of bypass. Carefully prepare of the donor artery before making bypass. Create a bypass carefully. Correctly close of the wound. Always suture of the donor artery bed after harvesting the STA, and take care of the vascularization of the skin flap, always. Thanks for your attention. Hvala vam na pažnji. Go secho, arigato gozaimashita.
Thank you very much, Professor. Spasibo vam большое. So that was an interesting and very educational talk, especially about the complications of bypass surgery. Believe me, I've seen all those complications in my life. So thank you very much for educating us. So I would request Dr. Adi to please make some comment, or we can ask the discussion about their comments. Dr. Adi?
Thank you, Dr. Sachin. Thank you, Professor Dubovoi, for a wonderful lecture and from your great experience, as I know, in bypass surgery. However, you already have mentioned in conclusion what Dr. should be avoided.
You're not audible.
Do you hear me?
Yes, we are hearing you.
Okay, so you already mentioned how to avoid those complications, and what I'm interested about is which is the percentage of the complication in the start of the bypass surgery, as well as for which major indication do you use bypass? What about steno-occlusive disease of chronic steno-occlusive disease, which we can see in younger and older population? Thank you.
Professor Adi, I have an answer for this question. About steno-occlusive disease, we perform bypass, low-flow bypasses for treatment of steno-occlusive ICA disease only in cases of inadequate blood circulation after several ischemic episodes of the patient, not only in cases with ICA occlusion. We take to surgery only patients with several ischemic complications.
Thank you. We have one question from from the audience. Dr. Shabazz Biswas, please, you can ask your question.
Hello, sir. Hello, Sensei Kato. Hello, sir. It's Dr. Shahnaz from Dhaka, Bangladesh, sir. I would like to ask two questions to Andre, sir. Sir, my first question is there any strategy you follow during harvesting STA to avoid the ischemic complication? And the second question is, how do you study the flow of blood via the digital subtraction angiography? I mean, is there any protocol you follow so that there is no controversy after the bypass?
Okay, thank you. So thank you so much for your questions. First of all, to avoid ischemic complication after harvesting of the STA, yes, about STA question, yes. To avoid skin ischemic complication, I need to perform a large skin flap. If I harvest only one branch, another branches performing vascularization of the flap. After harvesting, I always suture the bed of the taken donor artery to avoid ischemic complications along the bed of the taken artery.
Okay.
And the second question, to study the flow after making bypass, I usually use three methods. One of them, intraoperative contact Doppler, to study the speed into the arteries and the patency of the bypass. Next method, I usually use a flowometer to study the volumetric blood flow inside the connected arteries inside bypass. And sometimes I use ICG flow 800 to study the perfusion of the vascularized area to exclude the ischemic territories after making bypass.
Sir, one more supplementary question, sir. After bypass, if you had to take the DSA, do you take a specific injection or just common injection? I mean, common shoot or specific vessel shoot? I mean,
yes.
ECA
Okay,
or common?
We perform in routine. We perform only CT angio. In difficult cases, we perform DSA. We perform super selection angiography. We perform injection into the isolated into the external carotid basin.
Sir, okay. Thank you, sir. Thank you.
Thank you.
Thank you for your answers and questions. Since we have to stick to time, we have to move later. So, Dr. Kabulo, you can ask your question later if we have time on the end of this part of the lectures. So, the next speaker is expert in skull-base surgery, Professor Takeo Goto from Japan. So, please, Professor Goto. The lecture title is Endoscopic Skull-Base Surgery.
Okay. Today, I will talk about the endoscopic skull-base approach to various skull-base tumors. Our university is one of large skull-base center in Japan. So our old mentor, Professor Hakuba, started the transcranial skull-base approach, and our mentor, Professor Ohata, and I also follow his technique. So I think that even now the transcranial microscopic skull-base approach is a very useful procedure to reject the skull-base tumor safely. But recently, endoscope is well developed. So now it can be another option for safe resection of skull-base tumor. So today my topic is endoscopic skull-base surgery. One is endoscopic endonasal, and the other is endoscopic keyhole transcranial approach. At first, I will show our endoscopic endonasal skull-base approach. This is our classical transcranial skull-base approach. If we master this transcranial skull-base approach, we can reject most part of the skull-base tumor by the microscopic skull-base approach. But if the region located pure central skull-base within this circle, which connect all neural foramen, surgical resection around this area a bit difficult. But recently, if we observe this circle through the endoscopic endonasal view, the only obstacle to access this area is just bony structure, such as clivus, pterygoid process, and petrous bone. So if we adequately drill out all bony structure, we can directly access within the circle without any retraction of the neural structure or vascular structure. So this is a relatively large diaphragma-cella meningioma. This tumor severely compressed hypothalamus, and the tumor completely within the circle of Willis. So transcranial resection very difficult, but attachment is here. So in such situation, if we choose the endoscopic endonasal approach, tumor resection not so difficult. This is a diaphragma. We already devascularized, and this is a carotid artery, and this is a perforator from the PCON or PCA. So the tumor was easily resected out. And also now we can water tightly seal the dural defect using the suture technique. We make the knot outside the nostril and slide in the knot to deep seat area. So after the surgery, all tumor was safely resected out with preservation of pituitary function and vision, and also dural defect was completely water tightly sealed. So this is very less invasive approach to central skull-base. This is a retrochiasmatic craniopharyngioma. This case also endoscopic approach very useful. This is a surgical view. This is the oblique nerve, and this is a pituitary gland. After cut the cella floor, I elevated the pituitary gland upward and drill out the dorsum cella and also drill out the posterior clinoid to enlarge the surgical corridor. After this bone work, we mobilize the pituitary gland from the medial wall of cavernous sinus, and Then I cut the dura, dorsal side of the dorsum sella. So now we are completely within the circle of willows. So we can achieve the good dissection from the pituitary stalk, optic chiasm, and this is a perforator. All tumor was successfully resected out through the endoscopic enonasal approach. So this case also tumor was safely resected out with preservation of the pituitary stalk and gland. To enlarge the surgical corridor, bilateral posterior clinoidectomy is very useful technique. And then this is another case of pure lower clival meningioma. If we plan to resect the transcranial approach, we have some risk to damage the lower cranial nerve. But attachment is here. So if we choose the transcranial approach, we can directly access the attachment of the tumor. This is a basal artery. This is a tumor around the lower cranial nerve. But all tumor was resected out without any retraction of the lower cranial nerve or brain stem. So most part of the tumor successfully resected out without any deterioration of lower cranial nerve function. So now this part of the tumor also safely resected out. How to make the knot outside the nostril is very important for watertight closure. We published a technical report to World Neurosurgery. This is another case of the chondrosarcoma occupied the cavernous sinus. But also this tumor safely resected by the endoscopic enonasal approach. Now we choose the transpterygoid approach. This is a cavernous sinus, and this is a paraclival carotid artery. At first, I widely expose a carotid artery, and this is the pituitary gland. So now I cut the medial wall of cavernous sinus, and then go into the tumor. This is a bony tumor, so all cranial nerves shift upward or lateral side. So we can carefully resect it out with preservation of the cranial nerve and the carotid artery. This is a carotid artery. We resect the tumor behind the carotid artery like this. And finally, the all tumor was successfully resected out, and the arterial flow was checked, the ICG endoscope. This arterial flow completely preserved, and the tumor was resected out. So how to mobilize the carotid artery also very important technique to perform such kind of advanced procedure. And then I will show the endoscopic keyhole approach. Endoscope can offer the panoramic view to deep city area. So some tumor resected just a keyhole. This is an olfactory groove meningioma. This is a good candidate of the subfrontal keyhole approach. To resect such tumor, just 3 centimeter subfrontal craniotomy is enough. After insertion of endoscope around the frontal base, we can get very clear view to perform the tumor removal. And finally, all tumor was resected out like this. This technique also published. Subtemporal anterior keyhole approach, anterior petrosal approach is also very useful to see the around petrous tip. This is a trigeminal schwannoma on the right side, but endoscopic keyhole approach is very useful to resect such kind of the tumor. The size of craniotomy is just 3 centimeters. And then even under the endoscope, we can drill out the Kawasai's triangle. And after open Meckel cave, we can resect out the tumor like this. So finally, we carefully dissect the tumor from the neural structure and the tumor was resected out. This approach also can be applied to the small or medium size of petroclival meningioma. Surgical procedure same. This is a Kawase's triangle, petrous apex. I drill out the petrous apex under the endoscope. And this is a tentorium. We cut the tentorium and then dissect the tumor from the brainstem. The craniotomy is small, but endoscope can offer very clear, wide panoramic view around the petrous apex. So, using this technique, we can safely dissect out the medium or small size of petroclival meningioma like this. Another good indication of the keyhole approach is Falx meningioma or falcotentorial meningioma. If we insert the endoscope, it's relatively easy to see the falx and the tentorium around the deep-seated area. So we place the patient lateral position. This is a superior sagittal sinus, and this is a craniotomy. The size of craniotomy also 3 centimeters, but after insertion of the endoscope, we can relatively clear view. This is a falx and this is a tentorium. So detachment of the tumor is relatively easy. So we can safely dissect the tumor from brainstem. This is the MRI just after the surgery, but the tumor was totally resected out and the posterior lobe is already move back to normal position. So this is very less invasive procedure. If the size of the tumor is large, but attachment is the same, in such case, endoscopic endonasal approach, endoscopic keyhole approach can be applied. Surgical procedure also same. Craniotomy is the same. And after devascularize the falx and tentorium, we can mobilize the tumor and carefully dissect the tumor from the brainstem. So all tumor was resected out and also deep venous flow completely preserved and posterior lobe not damaged. So this keyhole approach also very effective. So of course, microscopic skull-based approach is a standard procedure, but to selective case, endoscopic endonasal or transcranial approach can be very effective procedure for removing the skull-based tumor. Thank you for attention.
Thank you very much, Professor Takeo Goto, for an excellent presentation about the various endoscopic skull-based approaches. Maybe we can take one question. I request Dr. Cabulo. Dr. Cabulo, you have any question?
No.
Okay, then in that case, I request the discussants of today's session. We have Professor Abuzor Gunbor to please kindly make some comments, especially he's an expert in the anatomy. So please make some comment about Professor Takeo Goto's presentation.
Hi, Takeo. It is nice to see you here. For young neurosurgeons, I think also it is better to start in endoscopic skull-based surgery, but for transcranial approach, I think they must start with microsurgical approach to learn anatomy and their relation with the other structures. What is your opinion in this issue?
Thank you, your comment. As you mentioned, also the microscopic skull-based approach is the basic procedure to learn the skull-based all procedure. So at once, a young doctor should master the classical microscopic skull-based approach. And then in selective case, we can use the endoscope, but the dissection technique or strategy is the same. So at first, as you say, the microscopic training is very important. This is a comment for young neurosurgeon.
Thank you.
Thank you, Professor. I agree. Certainly, microscopic training and learning the anatomy first is important step before you go for endoscopic approaches. So, in view of time, I think we can move ahead with our next presentation. Thank you very much, Professor Takeogoto, for excellent presentation. So, I request Dr. Kabulo to announce our next speaker and the title of his talk. Dr. Kabulo.
Okay.
Dr. Kabulo.
Thank you so much, Dr. Sachin. Now we are moving to our third speaker, who is Professor Samir Smajid, who is going to talk about single position spine surgery, benefit and simultaneous dorsoventral approaches. So, Professor, welcome, and it's all yours.
Good morning from Europe, or good evening anywhere, good night. I'm happy to be here and to share my experience with single position surgery. I will share my desktop. One second. Not working. Sorry. Some difficulties, sorry.
You have now to press on slideshow.
I don't know, it's not working.
Okay. You can stop sharing, then you restart.
Yeah, I try.
In the meantime, we congratulate all organizers, especially Kato Sensei, for this initiative. This is a very good one, and I think this is just the beginning. The beginning is always difficult. We'll continue in this way, and in the future, we'll do more than this. Thank you so much, Kato Sensei.
Okay.
Yes.
Now you can see my screen. I'm sorry for the disturbance. So I'm going to tell you about my experience in single position surgery from the lumbar spine. I have some disclosures. I go through cases and explain the technique. So this is a standard female, 51 years old, normal figure, nothing special. She has a spondy in L4-5 with no disc left. And this is a classical case, I think, for TLIF or PLIF approach. And I did this with single position surgery, and I will tell you why. First of all, there is no disc space, so usually we have to have big decompressions do the big decompressions, and we struggle sometimes to get into the disc space, and we cannot properly put big cages in such cases. So using single position surgery can make these problems easier. As you see, you have some spinal stenosis and a classical spondy, nothing special. My surgical plan was to target only L4-5, do decompression because of leg pain, and do the decompression indirectly by repositioning and restoring the disc height. So how can we achieve this? We can achieve this easy with a simultaneous approach. This is the standard positioning of the patient. Nothing special. This is how the patient looks like when it is covered. You have a good approach here from the side to get into the disc space via XLIF or LLIF. This is the first we start with the procedure from the back. We use retractors to distract the disc space, and here you can see after putting the screws and putting in the retractors, you can distract the disc space, and you have enough room to come now from XLIF from the side and make easy preparation. Here you can see how the cetus looks like when doing the simultaneous approach, before starting putting the lateral retractor into the human body. Here you can see the positioned retractor ideally on the X-ray on the left side. You see it's like an XLIF in lateral position. This is a video how we can look into this area using neuromonitoring to check nerves, like similar to the lateral XLIF. Here you can see pictures from the cetus. You have a good view, even in prone XLIF position. And in the end, after distracting L4-5, you can put a big and a long cage. You can restore the height and restore lordosis. And after putting the cage in, you can now do some rest, repositioning, and compressing to get lordosis. And this is the result after surgery. Full reconstruction of L4-5, and no need for direct decompression at all. So it's all indirect decompression. The next case is another very standard case, thin patient, female, healthy, with severe problems, degenerative problems in her lower back. She has osteochondrosis, L5S1. It's the main problem, and the other problem is in L4-5, compression of L4-5 on the right side. These are her parameters. She is well balanced, but it is very interesting to see that these discs above the huge degenerated lower discs, that the discs are highly angulated, and this is the compensation system. She has a good lordosis, but she has to overcompensate the discs. This is how the MRI looks like. And my surgical plan was to target only L4-5 and L5S1 to get a good restoration of the lower lumbar spine, to make a relief on the other discs, that they don't degenerate further, not too fast. Do a fusion of L5S1, do a fusion of L4-5, and do an indirect decompression, especially in L4-5. Doing it in a single position surgery is always in good hands, an increase of OR efficiency, and this can lower costs and make surgery going faster. And it is a simultaneous approach where we have full control of anterior and posterior parts of the spine. We can restore and we can correct a lot. The position of the patient is like that. It's a classical XLIF lateral decubitus position, and we have to have access from the back, from the side, and from the front. And this is how the patient looked like draped. I always make some marks on the patient to have a good orientation, front, back, and on the side. And this is how the surgery looks like from the side. I don't use navigation. I get used to only X-ray based surgery, putting screws, and it works very well. And this is how it looks like from the front. After putting the screws on the back, I do the anterior part, the ALIF, in a minimal invasive way called the technique X-ALIF or lateral ALIF. In the end, you have a good sight into the disc space L5-S1 on the left side. You see you can work simultaneously back and forth. And here on the right side, you see the cage and the screws, and still both approaches active. After finishing the anterior part of L5-S1, I start the anterior part of L4-5 because we have not much retractor time because of the psoas and the plexus. We need to be fast then. And the combination of three approaches look like that in real life. We are full active. We are working from the back. We are working bilateral. We are working from the side, and we have a full control to restore lordosis, disc height. We have a lot of much more possibilities than working only from one side. In the middle picture, you see that you can level up the disc space, and the screws are in, and the rod slides. On the left side, you see when you're preparing L5-S1, the rod slides, and you can temporarily fix them if you need to. You can give more decompression or extension from the back while working in the front. And in the end, you have a very nice reconstruction. And this is how it looks like. Before she was well balanced. Afterwards, she's well balanced, but have a look at the disc spaces L1, 2, 2, 3, 3, 4. They are all like, they don't have so much lordosis anymore. They're balanced, they're fine, and they won't get that fast degenerated. And the last case is a very interesting one. It's a revision case with heavy back pain and sciatica. Had prior surgery in 2010, had a flat fusion of L4-5 and the 5-S1, and the second surgery in 2021 with a TLIF due to adjacent level instability. And it looks like that. The fusion of L5-S1 is a solid bone fusion, but it's a very flat fused lumbar spine, and L3-4 is, to my mind, very bad fused as well. So this is the history of the patient. On the left side, this is how it started with a big degeneration of L5-S1. Afterwards, 2-level fusion, and then L3-4 got degenerated. And because of the low, because of the very weak lordosis, she got an spondy in L3-4, and the spondy was very bad treated, and she needed revision surgery. So what to do? Doing a bigger surgery instrument more, doing PSO. What can we do? Single position surgery can help us to restore lordosis by in prone positions. So you can have a back and forth control. You can have new screw directions, do a dorsal osteotomy, do a dorsal approach to the cage, distraction of L3-4 from the ventral and dorsal simultaneously, taking out the cage from lateral as possible, and then restore the lumbar lordosis by a huge cage. In situ, it looks like that. You have a good view in prone from the side. You can see the disc space, and from back, you have to open a little bit more because you need some more osteotomy as it is an ACR procedure. And this is how it looks like after surgery without taking without taking more segments or fusing more segments. You just do a revision in one segment, and we can restore 45 degrees in one level. Here is in a postoperative CT scan because she had some alterations with her nerves due to a long retractor time, but this resolved. But you can see it's a very, very huge reconstruction. It is a mega monosegmental correction potential when using this technique. It is similar or maybe even better to a PSO, but you have to take care of the neuroforamina in the back. It is a floating situation during surgery, so you have always you need this control from the back to put the screws and not to allow the vertebra slide down, but it helps us. Single position surgery, to me, in experienced hands, when being familiar with XLIF and XALIF procedures, can lead to a high OR efficiency with time reduction, with complication reduction, and cost or waste reduction. It is OR time is a very, very predictive thing in perioperative morbidity. So you can lower perioperative morbidity through shorter OR times. And using screw placement via navigation is not so screw placement is not a problem when having navigation on site. But single position surgery is not always, let's say, better. Pro dual or pro triple position is, I think, one major thing is screw placement. Still, it's more comfortable in prone. But if you do prone single position surgery, you don't have these problems anymore. When you need additional direct decompressions, it is useful to do maybe a dual or triple position surgery. But Thomas described in a very nice overview of his work that indirect failure rate is only 1.7%. If working in lateral decubitus position, sometimes you need posterior osteotomy, and then you need another position of the patient, or if it is possible, you can do it in prone if it is L4-5 or higher. Then this benefit of more positioning is not important anymore. My experience of 38 cases in 2-level single position surgery, including ALIF, XLIF, or double XLIF procedures, it is an average surgery time of 129 minutes versus 2-level TLIF 170 minutes versus 2-level dual position. You can see you can save time. TLIF is still faster, but TLIF cannot restore the sagittal balance like this single position surgery. As you see, I have an average correction of 25 degrees, and it is definitely even better than a two-level dual position anterior posterior approach, where I get an average of under 20% reconstruction of the sagittal balance. So why SPS? High operation room efficiency, simultaneous control of the spine, and better correction. Thanks.
Thank you so much, Professor, for that wonderful presentation. I want just to remind you that Professor Samir is a director of the Department of Spine Surgery at the Eduard Das Hospital, Cologne in Germany. So now I'm calling Professor Maurizio, if he's there. as a discussant? Before we take one question only, is Professor Maurizio with us?
If he's not, I can ask one
Yes.
question.
Yes.
Hi, Professor Sami. It was a nice presentation. And what kind of difficulties did you have when you start this position?
Okay.
Is there any learning curve or?
Yes. Very important when starting with these surgeries. You need to be experienced in XLIF or lateral lumbar interbody fusion. If this technique is familiar to you, then the learning curve is less. A little bit orientation in the start, first 2-3 surgeries, let's say, especially in the prone position, where you do XLIF and dorsal instrumentation. This is quite fast to learn, to my opinion, and you should start with L3-4 or L2-3, not L4-5. And then it is experience. When doing, let's say, ALIF or XALIF in lateral position, first you have to be, I think, trained ALIF surgeon or have a good access surgeon. Then you don't have to hesitate if you're a good ALIF surgeon to do an ALIF and XALIF in one position. To do an XLIF and XALIF in one position, it's easier. It saves you time. You can start with this. So do the cage, and then in the second part you do this posterior instrumentation, and later you can do it all in one. So you need step by step to come to this results.
Thank you so much, Professor. Unfortunately, we can't take more questions. Please kindly ask all participants to send their questions on the Q&A or in chat, so speakers can answer directly in the chat. So, Dr. Sachin, I can hand over to you.
Sir, can you allow me one question just?
Sure, Prof. Maybe just one question. We'll take a quick question. Professor Ibrahim.
Sir, it's an excellent presentation. So just to know, for L4-5 grade 1 listhesis, what are the points you consider to go for ALIF rather than TLIF?
Which are my considerations? So it is, I think, the most important segment of the spine. You have, if you restore a disc height and you make a big lordization in L5S1, you restore all the problems in the lumbar spine. So it's for me the most important reconstruction area, and as far as is possible, L5S1 I do ALIFs.
Thank you very much, Dr. Sam. Dr. Ibrahim has a hand raised since he is one of the hosts. Dr. Ibrahim, quickly your point, please.
Thank you, Shaheen. I would like to thank Dr. Smajic for his wonderful lecture. Even for us microsurgeons, sometimes it's strange. So extended small surgery, we can do some simple cases, not like this. I would like to thank you and congratulate. And I would like to ask you: do you always use the titanium cage or sometimes P cage? Or yeah.
Always titanium. It is better, or to my mind, better osteointegrative, as I have done maybe 4,000 spine surgeries. I rarely have to go back to take out an titanium cage, but I have very often revised plastic cages. So it's my feeling. I would prefer titanium.
Yeah, thank you. Thank you. Enjoy with us. Shakin?
Thank you very much, Prof.
That, Professor Kato would like to say something, maybe. Yeah, I saw she. Okay.
Okay, so we'll move ahead. Thank you very much, Professor Sam. I will take your email from Dr. Liu, and some young enthusiastic neurosurgeon, they'll be happy to have some time spent with you, maybe a 1 month short duration, 1 month, 2 months. Is that okay, Prof, if any of the young neurosurgeon comes and spend some time with you?
Sure.
Sure.
I would
Thank
be
you.
happy.
Thank you. Thank you very much, Prof. So let's move ahead with our next talk. And our next talk is by Professor Mirza Moranchik. And the talk is about hybrid or dual trained vascular neurosurgeon, a paradigm shift. So over to you, Professor Mirza. Are you there?
I can't see him. Maybe the problem with connection. Adi, is it here?
I don't see him too. Here, maybe we can move with a lecture of Professor Ibrahim Omerhodzic. So we will wait for Professor Mirza to be with us.
Sure, we'll do that.
Okay, then I can continue with the session. I think so. We are on time. My lecture is, I will try to be short, not so extensive, and also give some points, some interesting tricks and for the younger guys. So it's my lecture on the screen. Shakin, you see it?
Yes, Prof. We can see it.
We can see it clearly.
Okay. So we are working in the University Hospital in Sarajevo.
Maybe you can use the presentation mode.
Presentation mode, you don't see it?
No. Right inferior corner.
Just do the full screen. Yeah.
Yes. Yes.
You see it?
Not yet.
I did. But my screen is shared or not?
Yes. Yes. We can see your screen. Or you can press S5, F5. Yeah, slideshow. Yes.
Yeah, first one from the beginning.
Can you see it?
No, we don't see it.
Again?
We see your screen, but we don't see a full screen. Just go for a full screen.
Yes, I have full screen on my computer, but you cannot see it. Yeah? Huh?
Okay, you can just stop sharing your screen, make it full screen, and then share your full screen. Okay.
Yeah, let's do that. Something goes wrong. I don't know what's happened. Usually it works.
We can see your screen, but still it's not a presentation mode.
Yeah.
Yeah.
It's okay. So
yeah, it's okay. You can continue.
Yes, we can see. Let's continue, please.
Yes, you can see. Yes.
Please.
Okay, there will be a problem maybe with the video, but let's
see.
do with that. I don't know what's happened. So I would like to share with you some experience with strange cases in the cerebral pontine angle. So usually we know that there are mostly tumors there, and that it's 10% of intracranial tumors. And when we see the masses in the cerebral pontine angle, usually we expect the vestibular schwannoma, which counting approximately almost 80% of all tumors in the CPA. However, Sometimes we can find the meningiomas, epidemiomas, arachnoidal cysts, dermoid cysts, lipomas, even vascular metastatic tumors, and so. Our teacher and friend from Germany, Hanover, Professor Sami, which probably has the largest area of those tumors, we learned from him, but the story started at the end of 19th century with Sir Charles Balance, who first successfully removed the vestibular schwannomas. We know all the different symptoms we can get from those lesions there, and they are different depending of the localization of the tumor and its size mostly. And I don't want to go in deep, but we have that. We know that we have the sometimes compression of the brainstem, and which can produce even the hydrocephalus and some cranial nerve problems. And we call those collection of the symptoms like the CPA angle syndrome, and which can also include the hemiparesis, ipsilateral hemiparesis, hearing loss, and something like that. Of course, the anatomy there is very complex, and we know that the cerebropontine angle has the different borders and walls, 4 walls or 5, even 5 walls are around, and we have learned as much anatomy as possible to understand this complex pathology. This is animation from our teacher, Professor Rotom, who passed us a year ago. And as you can see, I hope, Shakin, can you see the video? That it changed?
No, we don't see it.
No, we're not able to see the video.
We see just the first slide.
Second slide.
Still first slide.
Yeah, still first slide. After the title, first slide.
Sorry. I'm on or 6th or 7th already. It's probably due to my computer. I don't know what's happened. Still first slide idea.
No, we are now on the 9th slide, but it's black. Just try to play your video if that is a video.
No, video is going on.
No, we don't see it. However, you may proceed with.
You see now the video presentation? I share it. I don't know what's happened. It showed me that everything is fine.
Sure, that generally happens when your Zoom software is not updated probably. So what you can do is either you can continue the presentation without the video, or if you have the video somewhere else saved, you can open that video and show it to us.
But you can see even this slide now, yeah.
Yeah, now we can see a slide number 10. Yes, we can see that slide.
And this one?
Yeah, we can see acoustic neuroma.
Okay, I will continue in this mode, so we'll see what's happening. So you can't see the video, yeah? Okay, however, so I would like I will try to show you video. It doesn't work. We will continue with that. I'm sorry for that. I don't know what's happened here. It usually works properly. So as I mentioned, there could be many different pathologies here, but usually we can find acoustic neuronomas. And what's very important to see on the MR pictures, which are still gold standard to evaluate the masses in the cerebropontial angle. And sometimes I would accentuate that it's very important to see this very sharp angle between the petrous bone and internal auditory canal. So if we see this picture here, it's probably schwannoma, not meningioma or ependymoid cyst or something like that. This is one of 4 cases, which was interesting. That tumor was large, and it was the remove course nicely, but control MR looks that we forgot the needle here, you see. But yeah, I was worried for that, and we make another scans and explain to patient that there is probably during the closuring of in this region, we forgot the metal part of our needle, but later on examination showed that it's actually artifact or MR machine. So, however, you should be careful. This is the story for the young guys. It is from my beginning of surgery in this region, that sometimes we don't worry for those small artifacts if we done nice surgery and patient is fine. So before we start with the surgery in this region, as I mentioned earlier, it's very important to lower this difficult anatomy with many vascular structures here, arterias and dandy vein, superior cerebral artery, inferior cerebral artery, facial nerve, glossopharyngeal, upper and lower, the cranial nerves. I would like to show you video, but if it doesn't work, I will go ahead. Can you see the video?
No.
Okay, let's continue without the video. I'm sorry for that. It was the surgery, how to remove the tumor there. Another problem which we have to thinking about are these cystic schwannomas, which are looks easier to remove, but they are not. They're actually much difficult than solid one, because those solids, the cyst, wall of the cyst, are very adherent to the cranial nerve, so sometimes it's very difficult to find a way to remove it, or even much better to left it there, some part of the wall. In this situation, approximately 5-6 years ago, I damaged it during the removal of the tumor. I showed this slide sometime to my colleagues. I damaged the 5th nerve, which is not usual situation. So we approximate the trigeminal nerve, suturing with one suture, and then I put the fibrin glue there, and I was surprised that patient recovered very well. The point here is to not remove all the wall of the cyst. It doesn't work. So left the path of the cystic wall of the cystic schwannoma. Another lesion we can find in the pontocerebellar angle are meningiomas. They are second most common lesion there. They are usually prominent near the cranial nerves and foramina, venous sinuses, and sometimes can be confused with the schwannomas. And but we should know that they are usually arise from the posterior surface, and they don't extend into internal auditory canal. So when we have some kind of meningioma, we know that they are mostly surgical lesion and should be surgically excised. And mostly we should remove it to the normal dura, and there is different approach in this region, but some suboccipital or retro or presigmoid or middle fossa approach are quite enough for the removing the meningioma in this region. There is some or case from previous years, and as you see, it's different than the schwannoma. There is no extension to the outer canal. It compressed the brainstem, but easier could be removed from the brainstem part than the schwannoma. And you see, after the removing, why I want to show this case, because it was too extensive approach. This is maybe 10 years almost ago. I hadn't so much experience in pontocerebral angle, so I did too big, too extensive approach to this lesion. We removed the tumor, let me say, easily, but this patient died 3 months later due to the unrecognized Acinetobacter meningitis. So I don't like to do large craniotomy. They don't need it. There is another video to show how to remove the pontocerebral angle and petroclival meningioma, but that doesn't work. I apologize again. So you see the postoperative MR, even this nice early postoperative MR shows the nice picture. The patient dies. I sent you to the meningitis 3 months ago, probably because we didn't close the mastoid cells well. However, this is another case of meningioma in this region, and this young lady had good surgery. I would like to show the video here. There is some tricks how to preserve the Dandy vein and how to preserve the trochlear nerve here and the fourth nerve and the sixth nerve, but this video unfortunately doesn't work probably again, so I will continue. I'm sorry. So the very important to not use the coagulation, and of course that if you have the ultrasound caviton aspiration tool, it's very useful and almost of paramount importance here. However, it's in the department with no option for use the CUSA. You can remove it in the piece by piece piecemeal technique. Another case I want to show you, we see that the foramen meningioma, which could be also extended to pontocerebral angle. What was the case here? Interesting to show is that after the nice surgery in the postoperative MR, we find the epidural hematoma. So the hemostasis in this region it's also very important. Also, we cannot find the ependymoma into pontocerebral angle. It's not usual location from the ependymoma, but sometimes we have to thinking for those cases comparing with schwannoma. There is sometimes calcification in this region, and also epidermoid cysts are sometimes in this region. Another case is a large tumor which is compressed, and sometimes if it's impossible to remove all the tumor, we can left the part close to the brainstem and send the patient to the stereotactic radiosurgery. Also, we can find the arachnoid cyst in the region, and to be honest, we should look at those scans a few times and talk with the patient. In many times, there is no need to do any action in this region, even that those cysts looks removable and nice to open, and even sometimes they looks like they're a little bit compressive, but mostly we don't need to touch the cyst. And if we're doing that, the small craniotomy or even endoscopic surgery, it's enough. Another case, another options in the pontocerebral angle are trigeminal neuroma, nice cases for the surgery, and let me say the very useful for the patient. We can use the middle fossa or even teneural approach, so it depends of the extension of the tumor, and many times the preservation of the trigeminal and the sixth nerve. it's not so big deal. Another vascular lesions could be shown in this region in pontocerebellar angle, like the ventral wall basilar dolichoectasia, which are rare cases, and the ICA loop, giant aneurysm, hemangioma, paragangliomas. And so you see one of the hemangioma in this region could be missed with the meningioma or schwannoma in there. Another case of glomus jugulare tumor, it could also be unrecognized and looks like the meningioma or even ependyoma. So the approach to this lesion, it's a completely different, not through the retrosigmoid approach, but beta or either through the translabyrinthine or middle fossa or even far lateral approach. And even better, if you can endovascularly treat this tumor, it's better for the patient and for you. ICA giant aneurysm could be also located in the pontocerebellar angle, and in this case, sometime flow diverter and endovascular treatment are could give satisfaction and satisfy the results, but sometimes we have to open there and make the microsurgery. There is the video how we treat those lesions here, but once again, it doesn't work. Sorry. And those aneurysms still are something we can operate in this region, or also ICA aneurysm. And this is another case which is interesting in pontocerebellar arteries, hemifacial spasm. There are some connection between superior cerebral artery and the dandy vein and terminal nerve and fascial nerve, and sometimes we put some small piece of the liodura or or even some glue, not only the Teflon, and we have satisfied results. There are the postoperative patient video how she's feel very well, and she wanna thank us for the very simple surgery. Once again, I would like to apologize to all of you for the video. Maybe next time I will show you. I don't know what's happened with my presentation. Probably Sachin is right that the Zoom is not up to date. I'm sorry, guys. Thank you. Adi.
Thank you, Professor Ibrahim, for a great lecture. Do we have any questions from the audience about the lecture? Okay. So now, since I don't see following speaker, Professor Mirza, we can move with the next lecture of Professor Abdesamed El-Ohabi, How to Develop and Implement Epilepsy Surgery Program in Africa, the Moroccan Experience. So Professor Abdesamed, you may proceed with your lecture.
Okay, thank you very much. Just thank you for everybody. Thank you for the invitation. I will share my screen. Do you see my screen?
Not yet.
Not yet. Okay. Now?
Now we see, but please do a full screen.
Yeah, okay. Okay. Okay?
Yes, it is okay.
Yeah, thank you. So just so the question is, in using this presentation, I will try to share with you our experience, how we develop epilepsy surgery program in Africa, mainly in Morocco, And I will speak about this preliminary experience. The first question, why development of epilepsy surgery programs in Africa is primordial, is essential. Most of you know that epilepsy is one of the most common chronic neurological disease with worldwide mean prevalence of around 9 per 1,000 people. In Africa, the prevalence of epilepsy is more higher. And we, according to one study done by a Moroccan colleague in 2021, there are more than 3 million affected cases. What is very interesting is that almost 2/3 of these cases are in children, and 1/3 of newly diagnosed epilepsies will become refractory. That means we should think about treatment alternatives. And 60% of all adult epilepsy cases are temporal lobe epilepsy. So the role of surgery and the aim of surgery is to try to have seizure freedom and improve the quality of life of this patient, and in addition to reduce mortality due to the epilepsy. In Morocco, we estimate the number of epilepsy cases around 400,000 cases, according to Moroccan population to around 37 million. 1/3 are refractory to medical treatment, and among them, at least 6,000 to 7,000 of patients might be candidate to surgery. The question was why there is no high number of performed surgery for epilepsy in Morocco, but not also in Morocco, but all in Africa. The reason for that are numerous. First, that there is no or very low number of dedicated centers. There is also a problem of reluctance of neurologists and patients for this treatment, and also along of many problem of misconceptions of the role of surgery in epilepsy management. So how we develop this and implement epilepsy program in Morocco, we proceed with 2 steps, 2 phases. We start the program in 2005 by doing surgery for temporal lobe epilepsy. And then after that, we go for more extension of indication mainly for extratemporal epilepsy since 2016. And we proceed thanks to the collaboration and the help of 2 teams. The first team from Europe, from Santan. We started the development in 2005. And the second team, 10 years later, thanks to the help of Professor Yuko Kato, a Japanese colleague team of neurosurgery, we go for the extratemporal epilepsy program, and mainly for doing cases of hemispherotomy and callosotomy. So this is our material. This is our experience I want to share with you. So far, we have operated more than 123 cases. And 83% are temporal lobe epilepsy, 103, and extratemporal lobe epilepsy, 20 cases. And to develop this program, we start by doing non-invasive evaluation on all the patients, because one of the program of this development of this surgery in Africa is the problem of invasive evaluation. So we saw that at least 2/3 of patients with epilepsy surgical can be treated by surgery using only non-invasive evaluation. And of course, the surgery was decided based on multidisciplinary approach in cases of perfect coordinates of electrophysiology, clinical, and morphological imaging data. And this is how we proceed. The pre-surgical evaluation, you can see after having the medical history, neurological examination, seizure semiology. We go for MRI, sometimes functional MRI, and video EEG, a neuropsychological evaluation, and sometimes we go to a PET scan if there is some indication. And then after that, we go for a resective surgery. Only non-invasive pre-surgical protocol was performed. And because in general, non-invasive methods are sufficient to proceed to most of the temporal lobe epilepsy. It has been proven that with this technique, we can identify accurately the foci, and according to and based on anatomy electrical communication data, and we can treat effectively and safely with LIROD surgery. The results very quickly. So this is very important to see that the main age of onset of epilepsy, it's a very young people, around 11 years. But you see that the median duration of epilepsy around 14 years. So these patients suffer for many, many years before they go to a neurologist and then to neurosurgery. And the type of epilepsy and the frequency of seizure, you can see that almost 43% have focal epilepsy, and 31% of patients had daily seizure. Almost 40% had weekly seizure. So it's very, very harmful. Drug treatment, the average is around 2 to 3 drugs per patient. So 55% have B therapy, 25% tree therapy. I mentioned that not just for the number, but in Morocco, the minimum salary is around $300 per month. And we try to make an estimation of the cost of drug in epilepsy. It could be around 150 to $200 a month. What might be around 25,000 to 35,000 for all the duration of epilepsy. And only 20% of the population in Morocco has medical insurance. So if we can afford for them a surgery that will cost less than 10% of this amount, it could be very, very interesting. So this is the result of the pre-surgical evaluation. Antericratal EEG shows in half of patient focal activity. The video EEG, more than 90% patient had focal abnormalities. And the use of MRI is, of course, in every patient. MRI can show abnormalities up to 70%, but it was normal in 30%. What the role of functional MRI? It's not, in my opinion, not mandatory in all cases of temporal lobe epilepsy, but it could be very helpful in specific cases. It was performed in 52 cases of our series. The functional MRI had the advantage of localization of speech and motor area, of course, and showed the relationship of epileptic lesion with functional area of brain. Since the use of functional MRI, you haven't used any VADA test, and I think that other centers that MRI has a reduced indication for the VADA test. What about the PET scan? The PET scan in selected cases, PET scan can maybe used to guide the strategy for more invasive expression, mainly the stereo EEG. It's not mandatory, as I said, for temporal lobe epilepsy. We performed it for patients, and the indication is when there is epilepsy with normal MRI, the PET scan can detect focal cortical dysplasia not seen on MRI, and most of the time, hypometabolism on PET scan is more extended than MRI abnormality, and this is very important for prognostic factors to predict the evolution after resective surgery. So these are the results in after evaluation in our series. In 103 temporal lobe epilepsy, the most dominant etiology is, of course, hippocampal sclerosis, and then DNET, some lesional abnormalities, glioma, focal cortical dysplasia, and cavernomas. In extratemporal lobe epilepsy, we had 4 cases of focal cortical dysplasia. We had 2 cases of Rasmussen encephalitis and vascular lesions such as IVM, cavernoma, frontal glioma, cerebral hemisphere atrophy in 2 cases, and diffuse cerebral abnormalities. So what are the surgical techniques we have used in this series? The surgical procedure in temporal lobe epilepsy, we used anterior temporal lobectomy in 91 cases and temporal lesionectomy 12 cases. And our surgical technique in temporal lobe is in our series is a classical temporal lobectomy with standardized complete excision of mesio structure. We don't use a selective amygdaloepicondectomy. This technique gives the best result in literature, and this is confirmed in our practice. We think that using this large approach may reduce the risk of having some part of the temporal lobe that is already modified by the epileptic seizure. And our results, our surgical results are within the range of success of the literature. And this is our technique. I would just go on the different steps. We start with the pterygolar craniotomy, a large posteriorly followed by a careful cortical exploration. And then we go for temporopolar anterior lobectomy, more extensive in right than left temporal lobe, with corticectomy of T1, T2, T3. We don't use transsylvian lobectomy, but we go first on T1, T2, T3, and T4, first by removing the neocortex, and then ablation of the subcortical white matter. We open the ventricle, the temporal horn, and we excise the hippocampus in 2 steps. First, the hippocampus circumvolution, then the Ammons horn, and then ablation of the amygdala. All the temporal lobe epilepsy has been treated the same way. This is some illustrative cases for hippocampal sclerosis and a very young patient with intractable epilepsy, left temporal foci and AG, and the MRI showed the mesio-temporal sclerosis on the left side. And we go for surgery, and you see this the results after surgery. Another cases of temporal lobe epilepsy, the DNET. This is a 12-year-old boy, refractory epilepsy seizure during 3 years with the left temporal lesion. It was DNET, and this is the post-operative after temporal lobectomy. In this case, we not only we remove the DNET, but also we extend the resection to the temporal, because on the video EG and the AG, there is extension of the epileptic foci to all the temporal lobe. Another case of temporal lobe dysplasia, it's a female, 32 years old, with left temporal lobe dysplasia. Here also, we go for a total temporal lobe lobectomy to be sure that there is no residual foci. Another case of temporal ganglioblastoma, a patient, a young patient with refractory epilepsy, and we go for also not just lesionectomy in this case, but also anterior temporal lobectomy, once again, because the video EG shows and the EG shows some electrical activity at the polar part of the temporal lobe. In extratemporal epilepsy, what are the surgical procedure we have done? We did lesionectomy in 12 cases and functional hemorrhaphy in 4 cases, 2 cases of Rasmussen and 2 cases of infantile hemiplegia with cerebral hemiatrophy. Callosotomy 2 cases, and we start to make some vagus nerve stimulation after very good selection of the patient. And this is cases we have seen: dysplasia frontal, corticofrontal dysplasia in the frontal lobe, and you can see on this slide has been operated with lesionectomy. This is a case we treated with hemispherectomy, functional hemispherectomy. This is right. This is a patient, 27 years old, female patient with right hemiparesis, consequent to neonatal left sylvian ischemic stroke. And you can see that at the age of 8 years, there is onset of temporal partial seizures, and with intractable. And the MRI, you can see this hemiatrophy, and we go for surgery. And you can see this is a periinsular functional hemispherectomy with 4 steps procedure. The first steps it was temporal lobectomy and amygdaloepicompectomy. You can see. Once we go for this lobectomy as a classical one, we open the ventricle, temporal horn, and then we proceed after removing the neocortex, and we proceed to remove the amygdaloepicampus complex. You can see here, this is on the hippocampus. And then we go for the supraansular entrance into the ventricle with removal of the frontal and parietal operculum. And then once we finish this step, we go for a transventricular parasagittal callosotomy. And you can see here, which will follow, this is the callosotomy, which was followed by posterior disconnection. And then the anterior disconnection of the frontal, anterior part of the frontal lobe. This hemisphere, to me, the post-operative was very uneventful, and we were surprised to see that there is patients try to recover hemiparesis immediately in the post-operative period, and by physiotherapy. Now she got married, and this is very, very important if you can modify the quality of life of the patient. So what are the results? You can see here on the there are 0 mortality and 17% of overall complication rate. Most of the complication was meningitis, 4 cases, hemiparesis 3 cases, but this is in concordance with the literature. And what about now the outcome? 86% of patients achieve Engel 1 for less than 2 years, and 80% will maintain Engel 1 after 2 years. This is a very, very good result, and is in concordance what is in the literature when the indication are good, and the selection of patient is very done with very strict indication. So there are some factors that we found that are not very good for the post-operative results. When the surgical resection this is factor that when the surgical, when the good factor prognostic, when the patient has operated for apicampal sclerosis, this is a good prognostic factor. When the surgical resection is complete, this is a good factor, prognostic factor. If there is a lesion in MRI also, if there is a good correlation between preoperative EEG and MRI, no evidence of cortical dysplasia, and no evidence of malformation of cortical development. The history of febrile seizure in medical history is a good prognostic factor. This is bad prognostic factor with the patient presented with a long duration of epilepsy before surgery, where there is a higher age at time of surgery. If there is high seizure frequency at baseline before surgery, and also if there are some post-operative seizure, early post-operative seizure, this is a bad prognostic factor. And also if there is some post-operative anterictal epilepsy for discharge. So there is a need for early surgical treatment in many patients with epileptic surgery, with epilepsy cases. because the seizure causing progressive neurological deterioration. There is severe accident associated with the seizure. There are many adverse side effects of anti-epileptic medication, in addition to the problem of cost in Africa and many country and low and middle income country, also the psychosocial consequence on the patient before and after treatment. So in conclusion, epilepsy is a real burden in Africa and in the world. When epilepsy surgery is done at the right time, it is 5 times more cost effective than lifelong medical management. Early surgery is essential to minimize the various side effects of epilepsy treatment and to improve the quality of life of the patient. Of course, the success of starting an epilepsy surgery program is based on multidisciplinary approach and support from other experienced team. And this is a teamwork and this is acknowledgement for all the participants in this program. And thank you very much.
Thank you so much, Professor Elwabi. Congratulations, félicitations for this wonderful presentation. I want to call Professor Abuzer for the comment, if he's with us.
Yes, Professor Abdulsamet, and I want to thank your presentation. And also, I did the anterotemporal lobectomy or selective ones. In the selective amygdaloid hippocampoectomy, the problem is from anterior, it is difficult to remove the posterior part. But I'm working also Professor Ture, we are doing the supracerebellar transtemporal approach. In this approach, it is difficult to remove posterior part and also anterior part. And our results is good and acceptable and similar with the literature. And also you mentioned about the complications and visual deficits. With temporal lobectomy, it is not possible to preserve all the optic pathway. And when you do the anterior temporal lobectomy, in our all patients had superior quadranaptia. What do you think about these issues?
Okay.
Professor Abuzer. Professor Elwabi, do you have a...
Yes, thank you. Thank you for raising this question. It is possible to do a selective amygdaloepicompectomy using neuronavigation. It is very important. As you said, sometimes it's very difficult if you don't remove the neocortex. You don't get access to the mesiotemporal parts of the lobe. And this is the reason why we do this like classical traditional way, going for neocortex and having more room to be sure that we can remove the hippocampus until the tail. It's very important. The second, most of our patients, we found that there is some epileptic activities on the temporal pole. So we go for that also. The third question, you are right. For the problem of visual field effect quadrianopsy, we had some patients that developed this, but most of the patients, as you know, have suffering epilepsy for more than 14 years, having daily epileptic seizure. Having a deficit like that is nothing when you compare with the very miserable quality of life having epilepsy every day. But I agree with you. We do visual field exploration, but it's not for us. When you compare with the situation of the patient, it's not a very bad complication.
Thank you.
Thank you so much, Professor. We are moving to the next speaker.
Thank you.
Our next speaker is Prof. Edwin Mogere from the Department of Surgery, Aga Khan University, Nairobi, Kenya. He is also an chair of education committee of CAANS. So Professor Mogere is going to talk about vasospasm, paradigm change to early brain injury and delayed cerebral ischemia. Welcome, Professor. Karibu.
Oh, thank you so much. Thank you so much. Let me see if I could share my screen. Are you able to see my screen?
Yes, we can see.
Okay, I guess you can hear me. Thank you, Kabulo. Congratulations to the whole team, the young CAANS team, the team from Professor Yoko Kato and Professor Ibrahim. Thank you for inviting me. Rather than take you through a series of clippings and coilings that we do at Aga Khan, I think it's an important discussion going on as to the basic mechanisms and thought patterns that are becoming important when we consider treatment for ruptured aneurysms. And I thought it would be a good forum to what our thinking is and get some views from everybody as to how they think and how they consider this topic. We've had, my work is at the Aga Khan University Hospital, Nairobi, Kenya. I work with CAANS, as you have been informed. I would like to go through the outline of the discussion, a little bit about the background, the natural history of aneurysm subarachnoid hemorrhage, diagnostic pitfalls, to mention a few words so that we can build up to what is the current or previous paradigm, where the questions have arisen, what are the management areas that are yet to be clarified, and then we ask what evidence or methodologies do we have to consider that pathology, pathophysiology, and then where could we be going next. So for the coiling versus clipping controversy group, let me assure you I will disappoint you and I will not be participating in that broad discussion today. Aneurysms constitute about 1% of the population, and the aneurysms lend themselves good numbers to remember. The annual risk of hemorrhage over 10 millimeter aneurysm is about 1%. So it's easy to say that 10 in about 100,000 human beings will have an aneurysm rupture, which means considering perhaps there are 7 billion people, we should expect about 700,000 cases worldwide. And you can do that number for your population. In Kenya, we are 50 million, so we should be having about 500,000 cases of aneurysms walking around, and about 5,000 of those should bleed. But in effect, we only treat about 500 in all the entire public hospitals. So problem of recognition. And I suspect that is the same across the continent. They're also a deadly disease. Although they only constitute 5% of strokes, they constitute 25% of the mortality. So the case fatality rate is extremely high. And for the survivors, there are very many who have permanent neurological, cognitive, and functional deficits. On top of that, in terms of thinking about the process for aneurysms, I think it's important to note that we need to think of the disease of rupture of aneurysm beyond the coiling, clipping, and aneurysm security stage. We have to think of the disease process and how it affects the entire brain and body. This is an old diagram, most of you are aware of it. And is to say that at the point at which an aneurysm ruptures, 15% of patients will not even come to hospital. They will immediately go to the morgue. They will not survive. And of those ones, 30% who survive will eventually succumb within the first few days. So that the overall bleed rate of the overall mortality with a single hemorrhage is about 40%. And so on and so on. And I would not go through this entire diagram, but it's to just say, essentially, the worsening the degree of disruption as demonstrated by the severity of the disruption in GCS does reflect quite closely as to the mortality. So that's the first important point to say. How bad your GCS is on day one is probably the most influential thing that determines how many patients survive. That is a functional outcome in terms of survival, not neurocognitive, although it closely parallels it. Now, as we proceed, we can see that generally after you have a ruptured aneurysm, you can think of patients broadly in three different groups. The ones whose half-life is measured in hours, those are the grade 3, grade 5s, and the immediate mortalities who go to the mortuary and never make it to hospital, who have the worst of the disease. Then you have those ones in group B who are moderate disease, who are supposed to be sort of like the grade 3s. And those of us who treat the disease, most patients are in group A, whose half-life is measured in hours, who have the grade 1 and the grade 2 hemorrhages. And that's where we need to concentrate on. And as we can see, it has a very influential role in your life. Once you have a rupture, even your 10-year mortality is affected very drastically from the general population. We also know that the degree of blood has some role to play as to the degree of cortical disruption and neurological injury that follows. And we also know the general paradigms is once the diagnosis is established, you institute medical therapies, control the blood pressure, and so on and so forth. We then go on to secure aneurysms as quickly as we can. And we know that clipping is used in many places where there is no endovascular, but when you do have endovascular approaches, most aneurysms are secured by coiling. And if you have the capacity to do cerebral vascularization, that's another method. We also know that we have considered the outcome placed in using the modified ranking scale, where 0, 2 is considered good and 3, 4, 5 is considered bad. And I will have some words to say about that discussion maybe a little bit later, that may need to be changed a bit. We also know that we now have established that coiling gives a good treatment and it lasts well. But we also know that in many places, and clipping has been used for years and is also a good treatment. So how does that set us up? So having secured an aneurysm and treated the systemic complications, then mortality in the previous thought pattern was then ascribed really to vasospasm, which is a big word, and it means very many different things to different people. We all know that there was it, so that aneurysm which was secured from day 1 to around day 3, patients seemed to do well, and then from day 4, things started going off, and we saw new neurological deficits and things like that. And for the longest time, almost 3 decades now, a lot of money was spent in trying to elucidate what are the pathways through which this vasospasm, as we call it, was developing. And we knew that the 70% of patients have evidence on any angiography, whether CT, MRI, or DSA, of having vasal narrowing. And clinically, patients developed new neurological deficits, up to 30% of patients. And we then went to a long time to try and elucidate these principles. This is just an imaging demonstrating quite vasospasm and then the M1 on a patient. And so many on, and there's so many images which show this. And what we then thought for a long time was that once you had a hemorrhage from arterial blood, which carried loss of hemoxyglobin, then hemoxyglobin was the main driver of angiographic vasospasm, as we call it, because it triggered oxygen-free radicals and inflammation, which then led to endothelial cell injury, which consequently reduced nitrous oxide. And the controversy, or shall I say the counterpart to nitrous oxide is endothelium-1. They are antagonistic molecules. Whatever nitrous oxide does, endothelium does the direct opposite. So nitrous oxide is your vasodilatory agent of choice in endothelium, and endothelium-1 is the vasoconstrictive agent in endothelium. And so clazosentan was the first endothelium-1 receptor antagonist that was developed that directly was known to function and work in this manner and reduce angiographic vasospasm. But certain questions started arising even as we went through those thinking. So firstly, patients who were given oral nimodipine improved, but improved. Sick vasospasm. What?
Can anyone hear Professor Mogere?
No, we have the same problem.
Prof, you have a, I think, connection problem. We can't hear you anymore. No, you are crashing. Hello, Professor.
I can hear you. You can.
No, we can't hear you properly. Hello? Hello, Professor Edwin? I think he is... Okay.
You can hear me now?
Yes, we can hear you now.
Apologies on that. I'm not sure I lost you. Well, you lost me, sorry.
Yeah, we couldn't hear you, but from these slides, you can just go back to the presentation mode.
Okay. So,
Yeah.
Kabula, if I may ask again, where did you lose me?
Just the same slide where you were. Yes, here.
Okay, so this slide. Right. Apologies on that.
Okay,
So
no problem.
I think yes. So do let me know if you lose me again. I think the internet is probably not very well today here. Anyway, so the question started arriving because patients who were being treated on nimodipine did not improve purely because of angiographic vasospasm alleviation. At least 33% of them were improving, but still had persistent evidence of angiographic vasospasm. Secondly, not everybody who has angiographic vasospasm has neurological deficits. That's clear. And they also know that 21% of patients develop ischemic injury without ever showing any evidence of angiographic vasospasm. So we started asking questions, what really is the link between this vasospasm and clinical outcome? And there were many studies which came out. But I think from there, the real question came with the clazosentan, Conscious 1, Conscious 2, Conscious 3 trial, which all instantly showed either complete or very good alleviation of angiographic vasospasm, but none of them could show a mortality benefit. And in fact, some of them showed that a worse mortality outcome for those patients. And finally, the REACT study, which was amalgamation from all the Conscious study, when Idorsia released the results of the REACT study, it was a bitter disappointment that, in fact, although it works to relieve angiographic vasospasm very consistently and very well, it has no effect on the overall mortality and outcome of these patients. So then rethinking of this subject has now taken place, and perhaps it's better to think of this disease as going in two phases. So the two main ways to think about it, in the first 3 days, the patient is undergoing early brain injury. And after the day 4, the patient is suffering delayed cerebral ischemia. And those are the two key words, early brain injury, delayed cerebral ischemia. Although we separate them, of course, they are concurrent biological processes going on at the same time. We will consider early brain injury in brief at first. So what happens? An aneurysm ruptures, you have an acute infusion of blood into the brain, you have a precipitous rise in intracranial pressure, which then arrests the circulation, resulting in a transient global ischemia, and that can either result in 2 or 3 major pathways. If the ischemia is profound, severe enough, you have severe necrosis of the brain, you have infarction, patient dies. Those are the 15% of patients who go to the morgue. If it is severely profound, but not enough that it kills the patients, those are the subjects who come in as grade 3 and grade 4 and grade 5, who suffer a large area of necrosis, but also end up going autophagy and apoptosis, but not severe enough to kill them, but severe enough to really severely injure the brain and the endothelium. And it's important to remember the endothelium is a key injured organ tissue, not just the neurons and the glial tissue. Those survivors then will endure the early brain injury. What happens with the early brain injury? We have a transient global ischemia, you have the mass effect from the intracranial blood, and then you have the provocation of the sympathetic overdrive consequent to the brain injury because of the hypothalamic dysfunction. And this has profound effects. If you think about it, the basic way to think about it is that it's a SARS response, it's a systemic inflammatory response. Because if you look at all the complications of subarachnoid hemorrhage, there is no system that is not spared. You get myocardial ischemia because of the subendocardial myocardial infarction. You get cervicocerebral cardiomyopathy, which is an inflammatory myocarditis. You get ARDS, which is really pulmonary dysfunction. You get renal dysfunction. You get hematological complications. You, in fact, get a complication at every single organ system, and it all comes down to sympathetic overdrive in those particular organ systems. What does that lead to? That leads to the same complications happening within the brain. You have microcirculatory constriction, you have microthrombosis, and then you have destruction of the blood-brain barrier, which necessarily will then lead to vasogenic edema, and consequently you have cytotoxic and edema with neuronal injury. This is beautifully displayed by Luke MacDonald in his paper that he published as a review in 2013, which is to say that you are dealing with a severe neuroinflammatory condition within the brain, and many processes are affected. And this is already taking place long before you start worrying about clipping and coiling and revascularization later on. That's what you're dealing with. Now, after those first 3 days, you then proceed to the this diagram. I think it's a good from Park et al. About the processes that I have just described, and that you need to keep in mind even as you're treating your patient. That neurons are dying, and they will continue to die if you don't pay attention or you don't put as much emphasis on deciding surgical ablation as to these pathophysiological processes. And they probably are just as important, if not more important, I suspect. Then after that process has taken place, what then happens? Who gets ischemia? Who gets infarction? The effects of early brain injury are carrying on, which are leading to endothelial and neuronal injury and death. You then have certain patients who will get angiographic vasospasm, depending on the degree and endothelial injury. As a consequence, you also have problems with circulatory failure because you have microcirculatory with microthrombosis, platelet dysfunction, and so on, which then take place to conspire to cause worsening brain ischemia, which then leads to cortical spreading, depolarizations, and inflammation. All of this then decide which of these patients will eventually end up having infarcts, microinfarcts, and with then new neurological deficits or not, or which of these patients will not. So in other words, you have genetic variability and inherent you would say vulnerability, including apolipoprotein E, and also the degree of collateralization you have in your brain. If you have, and what degree, will conspire to put you in a position either to be able to salvage the situation or not salvage the situation, or salvage the situation in certain cortical beds and not in others. And that is how we then see a variability. So I think the best way to think about it, and this is a multivariate analysis, there isn't one factor that leads to this. There's a multitude of factors, both coupled with the pathophysiology and the genetics and the environment, that then would lead to a certain degree of injury. And it's important to consider that as you are choosing therapies. This is just a summary of all of dysfunction in autoregulation, microcirculatory failure, variations in collateral circulation, and then vascular anastomosis. And then the native metabolic and genetic variability will then what will decide which patients will follow this path, whether they will be in A, B, or C. Why is this important? Well, then if we are really going to make a change going forward, we have to consider this disease in its full complications. We have to make a decision or make decision from day zero, which path is this patient going to follow? Is this patient an A, a B, or a C? Is this patient in the worst category, somewhere moderately, or somewhere in the less category? And this is important because we may need to be very aggressive with certain kinds of patients, like we would consider a severe head injury. We also need to have biomarkers that may help us in deciding which patient's pathway they are likely to follow. We may then need to monitor those patients much more closely, not after the horse has bolted rather, but early, to select them early for early admission in neurocritical care, you need to institute monitoring early so that we have opportunities to intervene and change the course early. Importantly, it's also good to predict where they will go so that we don't do those invasive things in patients who have no need for them, which is probably a large group. So that's important. And then we will need to attack the disease at its process, apoptotic agents, antinecrotic agents. And then also important that we may need to change or look at the paradigm of how we assess outcome. It may no longer be sufficient to simply say the modified ranking score 0, 1, 2, 3 is okay. There's a very interesting study that was published from a subgroup analysis of the ISAT group patients who had been coiled versus clipped, and it was looking at the neurocognitive outcomes measured by the MOCA score, Modern Cognitive Assessment Scale. And although those patients were all in the good group, 0, 1, 2, there was a profound difference in the neurocognitive outcome in those patients. So that 30% of them in one group had a bad neurocognitive outcome and 70% had a really good neurocognitive outcome. So that the measures may need to take place not just for the modified ranking score, who survived and who died, but also the quality of the neurocognitive outcome they enjoy is important and needs to be addressed. And we're beginning to see some of the studies which are addressing that root problem. There's, as you know, there's an activity going on at the moment about low-dose heparin infusion, and it's important for me to emphasize this low dose. We are not looking at heparin as an anticoagulant. It's a profound anti-inflammatory, and we're looking at not the low molecular weight heparins, at least not yet, although that may come in future. But heparin as a low-dose infusion, which has got quite an interesting record of reducing neuroinflammation and improving neurocognitive outcome as measured by the MOCA scale. Many of you are aware of the Maryland protocol, as we call. We use that in our study. We use that in our center, although evidentiary basis is weak, and I am aware that there's an RCT going on at the moment. We're waiting to see the result. But all the current evidence in semantic review shows that not only does heparin improve neurocognitive outcomes, it improves mortality, but it has really very little role with angiographic vasospasm. It does this outside, not affecting the angiographic vasospasm. Second agent is cilostazol. Cilostazol is also well used, very well used in Asia. I'm sure a lot of the audience in Japan and China are quite much aware of cilostazol. And its role is an anti-rheology agent that reduces microcirculatory failure, improves microthrombosis flow, and it also has a very good meta-analysis to suggest and to show that it has not only an improvement as measured by the modified ranking score, but also has improvement in neurocognitive outcome in those patients as well. And then finally, the study that was published recently from Dapsone, which is agent that was used in treatment of leprosy, has been used in leprosy treatment in these parts of the world, is protective from neuronal death, and is now published from Mexico. Very good study that it shows that it improves not only neurocognitive outcome, it also improves overall outcome. All of these are, you may see, are drugs which are not really addressing vasospasm as a topic, but are really targeted at the pathophysiological mechanisms and trying to address the different roles of neuroinflammation and flow. Finally, thank you. I want to borrow this phrase. Many of you in college are aware of what they call the Blake-Cady principle, which was to say that in the world of tumors, biology is king. Selection of patients is queen, and the technical details of statistical procedures are the princes and princesses of the realm, who frequently try the powerful forces of the king and queen, usually to no avail, with some temporary victories. Let me suggest that in the world of aneurysmal subarachnoid hemorrhage, early brain injury is king, delayed cerebral ischemia is queen, and the technical details of surgical procedures are the prince and princess, who similarly try to overthrow the powerful king and queen, sometimes to some temporary victories. Thank you very much. Asante sana, arigato gozaimasu, and havla lijepa. Thank you.
Thank you so much, Professor, for that comprehensive talk. I don't know if we have time for a comment in 1 minute or we can move on.
Maybe I can add something. For my
Yes, Prof. 1 minute.
cases with subarachnoid hemorrhage, I always use a lumbar drainage. Maybe it can help to prevent vasospasm because you are removing the blood from the system. I think it can help because my vasospasm rates are lower than the literature, but I always use lumbar drainage.
Yes, yes.
We can't hear you, Prof. Edwin. We can't hear you. Maybe you can switch off your camera. Okay. Yeah.
Kabulo?
Yes.
Okay, brilliant. Yeah.
Yes.
Yeah, 1 minute. Yes, Professor Brooks, I completely agree with you. Being that uses the metabolic from the presence of hemoglobin in any form, lactate being one of them. And in fact, also certain studies show placement of an EVD as indicated and setting it at 0 to 5, ensuring after securing an aneurysm, quick egress of that CSF-led blood does demonstrate an improvement in the neuro and outcome and we go on. So I agree with you. Anything, it's just that I think we need to think of it that way. Rather than just securing the aneurysm, we need to know that we're in a metabolic battle with early brain injury and delayed cerebral ischemia, and we need to get in that as over and above.
Thank you so much, Prof. Mugere. From vascular, we are moving to trauma. This is now Dr. Ngobile Ntango from South Africa. Dr. Ngobile, she is my boss. She's the chair of Young African Neurosurgeon Forum, and she's a pediatric neurosurgeon at the Red Cross War Memorial Children's Hospital in Cape Town, South Africa. She's hosting the WFNS Congress in December very soon. We'll be with her there. So Dr. Ngobile will talk about multimodality monitoring in pediatric traumatic brain injury. Dr. Tango, boss.
Thank you so much, and thank you for the invitation. I hope everyone can see my slides, and I always like saying that
Not yet. We are still seeing Prof. Mogere's slides.
Really? Okay, let me stop sharing.
Yeah.
And let's try again.
Yes. Thank you.
Better. Okay. Hello, everyone. It's a pleasure to be here. And I always like saying that Prof. Mugere used to be my chief registrar. So it's very fitting that I follow after him. Thank you so much for the invitation, and we're already learning a lot together, and may this be the first of many more webinars together. Just to give a bit of background about myself, I'm a pediatric neurosurgeon, so I am from South Africa, and hopefully we will see all of you shortly. That is the southern tip of Africa, and I am based in Cape Town at the University of Cape Town. We were privileged enough for our institution to be voted the top university in Africa, and I'm a pediatric neurosurgeon. That means I work at this hospital known as Red Cross Children's Hospital, which treats children less than 13. And then I'm also a researcher at the African Brainchild Lab. A lot of the work that I'll be discussing today in terms of TBI is a lot of work that was started off by my clinical and research mentor, Professor Figaji. And as I give this talk today, I'll be giving it also on behalf of him, because unfortunately he sends his apologies about not being here. So in our lab, there's neurosurgeons and neuroscientists, and we strong believers in translational research. That means trying to get basic research from the bench to the patient's bedside to benefit our population group. So taking it back to traumatic brain injuries, we know that there are a major public health concern. If one looks at these figures released by the WHO, our infectious disease colleagues and physicians are doing very well, and one can see that there's been a drop in communicable diseases, but one can see that injury-related diseases are on an upward trend and are expected to be even larger over the years to come. So this is a silent pandemic. And when we take it to TBI, it's the most common cause of childhood neurological morbidity and mortality. It's a dynamic, complex process, which we're still trying to understand. And the role of multimodality monitoring, which I'll be talking about today, is still very poorly understood. And PEDS are a difficult cohort to research because their numbers are underrepresented. So when one looks at the global picture of TBI, you can't help but realize that it's skewed. According to research, there's a high incidence in the global north versus the global south. And we know that many of us treat this condition, and just taking context specifically with pediatric TBI, South Africa is one of the most unequal societies in the world. So we have a large population of our children that do not have playgrounds and end up using the streets as their playground. And we know that the risks of childhood injury are material deprivation and low socioeconomic status. And a lot of this echoes within Africa today. Specifically within Red Cross Children's Hospital, we have a prospective TBI database, and one can appreciate that MVA and pedestrian injuries are actually the highest. And this is a public concern for us, and we're working with our Department of Health to address this. So as the audience knows, when we look at traumatic brain injuries, it's divided into two. You've got your primary injury, which occurs on scene and is irreversible. So it separates the survivors from the non-survivors. And then once you survive, the clock starts ticking and secondary injuries at play, and it can be within minutes to hours. And this is the cornerstone of treatments of severe traumatic brain injuries, is to prevent or limit the effects of secondary brain injury. And as many of our audience know, this can be cranial or systemic. So within our institution, we use multimodality monitoring when we treat severe traumatic brain injuries. And historically, physicians have relied on neurological examination and imaging when it comes to guiding the management of severe traumatic brain injuries. But we know that these tools give a static picture of an evolving injury in time. So a shift has gone within the field of trauma to try lean more towards multimodality monitoring. This allows the treatment of the injury at not only the physiological, but also the cellular level, and it allows intensivists and surgeons to detect and treat the early changes of secondary brain injury. This gets done by the bedside, and I'll be talking about the components that we use and what a bit of what literature says about it. The work we do, we cannot do without our awesome nursing care and our intensive care units. We have dedicated nurses that also help us in monitoring the patients that we treat. So when we look at intracranial pressure monitoring, a lot of our thinking within neurosurgery has branched out in terms of how we think about raised intracranial pressure, has branched out from principles which were started by Alexander Monroe, who was an eminent Scottish physician. And many of us know that he said the skull's a fixed compartment made up of three components: blood, CSF, and brain, and a change in one of these components results in a decrease in the others in order to maintain homeostasis. And one of the ways that one can measure intracranial pressure can be clinical, if you've got an awake patient. Brain imaging, ICP monitoring is what I'll be discussing, and other non-invasive means. So when we look at intracranial pressure monitors, I just want the audience to keep in mind, we know that raised intracranial pressure is related with poor clinical outcomes, but due to a paucity of randomized controlled trials within this field, and this has resulted mainly because there's been inconsistencies in how we gather observational studies, there are very limited guidelines in terms of treatment of care. Beside this, the large body of clinical evidence does support the use of ICP monitoring to help the management of TBI. But just keep in mind that by no means what I'm discussing is the gold standard in terms of management, because TBI is an evolving field and one treats according to the context they're in. I've mentioned before that the two methods we use is clinical, and the GCA, specifically the motor score, has the greatest implication in terms of prognosis prognostic outcome. And then we've got invasive, which can either be an ICP or an EVD. Most of you know that the EVD is the gold standard because it allows for the measurement of ICP, but also the treatment via releasing CSF. In our institution, we use an intracranial pressure monitor, and this is a strain gauge pressure sensor fiber optic tip that gets put in the prefrontal motor cortex. You can put it 1.5 to 2 centimeters, and it gives us a reading. And we aim for an ICP of less than 20 and a CPP. For those of in our audience, I'm sure you know CPP is a surrogate for cerebral blood flow, and you work it out by taking your mean arterial pressure, minusing from your ICP. And in adults, we aim for a CPP greater than 60. In children, less than 40, between less than 4 years of age, and if they're greater than 5 years of age, greater than 50. And this is because children tend to have a different hemodynamic profile to adults. And then when one looks at ICP, we can't talk separated from cerebral autoregulation. So cerebral autoregulation is a physiological mechanism that maintains cerebral blood flow across fluctuating systemic blood pressures. And cerebral vascular pressure reactivity is a distinct component of it, and it relates to the ability of the smooth vascular cells to react to changes in the transneural pressures. So when looking at cerebral autoregulation, there's static and dynamic means of measuring it. Our static means you can use your mean arterial pressure. However, when you do this, you need to do provocative tests such as raising or lowering the blood pressure while monitoring your cerebral blood flow, whether you do it via transcranial Dopplers or your ICP. A lot of the time, these tests are invasive, time-consuming, and it's also technique dependent. Another tool one can consider is dynamic measurement, and this is where our cerebral pressure reactivity comes into play. So the cerebral pressure reactivity is arguably the most widely used indication in terms of the status of pressure reactivity in research studies, but there are a few very limited studies in children. We recently released a paper with the largest cohort to date at 56 patients, and we saw that the PRX has a strong independent association with outcome in children, but do keep in mind that within pediatrics, this is still a topic that's being researched. The next component of multimodality monitoring is a brain oxygenation monitor, and this is a monitor that measures the partial pressure of oxygen. We know that conventional physiological variables have a weak relationship with our intracranial oxygenation monitor. So your SATS monitor, in correlation to what's happening in your intracranial space, is not very good. So hence we've been moving towards LICOX or brain oxygenation monitors. And within our children and our cohorts, we found that it has the strongest independent association with outcome. Within Red Cross, these two monitors that I'm mentioning, the ICP and brain oxygenation monitors, are paid by government. So it's standardized treatment of care that we offer to our patients. And our clinical management, we tend to aim for oxygenation. Our triggers are of ischemia is an oxygenation of less than 20. And when it's less than 15, you start having severe ischemia. And hence, we tend to have our transfusion triggers between, we try to get our HB above 10 or at least greater than 7. Okay, another tool that we use, which is still being extensively researched, is the microdialysis monitor. And this is a semi-permeable membrane which you insert into the brain, and it basically acts as an artificial capillary where diffusion occurs. So a substance is pumped through that has similar concentration to interstitial fluid, and a pressure gradient occurs where molecules move from a high concentration gradient into the into our semi-permeable monitor. And what we're able to monitor here are metabolites of secondary injury, such as lactate pyruvates, which is surrogate for anaerobic glycolysis, and your glutamates, your glucose, and glycerol. And we're also able to get some drug measurements for drug studies. So we've been trying to look at biomarkers for secondary injury, and biomarkers are quite important because you kind of want to hopefully get an idea of whom to treat or whom to closely monitor. And this is the importance of all of us doing more research in TBIs to just get more standardized care. So what we found within our cohorts is that brain interstitial glycerol, which is released when there's cell membrane breakdown, had quite a strong correlation with evolving brain injury within our pediatric blooming contusions radiologically within our pediatric cohorts. So in our patients, when we start seeing glycerol climbing along with uncontrolled ICPs, we tend to send them to scan sooner rather than later, because most of the time this might mean the contusions are blooming, but obviously studies need to be done in other centers for this to be more widely accepted and validated. Other aspects that we're looking at now is pharmacokinetics in terms of how much of the drug reaches the CNS, and this is a great interest within our research group. And we interested specifically not only in TBI, but also in CNS infections. And the next biomarker, which we're working and hopefully working on as a group, is to see the genetics in terms of, are there some population groups which are more prone to have a different inflammatory reaction and tend to do worsely because of genetic predisposition in TBIs. And I think in South Africa, we're primed to do this because we're known as the Rainbow Nation. So we have a heterogeneous gene pool within our country. So thank you so much. And we look forward to welcoming you to the WFNS in Cape Town in December. Thank you.
Thank you so much, Dr. Ngobile. We can get one comment from one senior. Comment or question from one senior before we ask Adi to introduce the next speaker.
If there's none, that's okay. People can just chat on the chat box, then I'll respond there.
Of course. Okay. Is
Adi... Well, can I make one comment?
Yes,
sure.
Yes, certainly.
Just Dr. Nkubile, pediatric neurosurgery is very, very important in Africa. There are not many pediatric neurosurgeons, and you being a female pediatric neurosurgeon is an exemplary and is an big encouragement for many young neurosurgeons out there who can, do more work in this field, especially after seeing your passionate work. So all the best. I'm really impressed with the kind of work you're doing. All the best.
Thank you so much. Thank you, Session. Much appreciated. And thank you, everyone.
Thank you so much. Is Adi there?
Yes, I'm here. My apologies. I'm on and off since I'm working in the hospital.
Okay. Let me continue then.
Okay, please.
Our next speaker is Dr. Anes Masovic. Is he with us?
I think Dr. Fakhrudin will take.
Dr. Alik?
Yes, I'm here.
Yeah, are you the one presenting?
Yes. Here, just a second.
Okay. Dr. Alik is going to take us through how to develop and implement epilepsy surgery. No, I'm sorry. He's going to take us on spinal epidural abscess, operative or non-operative treatment. Thank you so much. It's all yours.
Can you see my presentation?
We can see it. Just go to the presentation mode.
Exactly. Is it good?
There you are.
Now, hello everyone. Good afternoon, dear colleagues and distinguished professors. I'm really honored, extremely honored to have opportunity to give a lecture as a part of this outstanding meeting, especially due to Adi and Professor Ibrahim. But first of all, I would like to express deep gratitude to, on behalf of all young neurosurgeons from Bosnia and Herzegovina to Professor Yoko Kato, since she enabled us a grant of funds intending to for training and further research. So thank you again, Professor Kato. My presentation is from field of spinal infection. I will at the end of the presentation, I will set two questions for discussion, which will refer of form of our treatment. And I would like to hear more senior neurosurgeons for their experiences, recommendations, and suggestions for whether they will do the same or something else. As we know, the spinal infections, we have major categories that are divided in something that is dealt by infectologists. There's something that not surgical part is oral spondylitis and spondylodiscitis, usually caused by pyogenic or non-pyogenic infection. But what is the matter of neurosurgeon part is spinal epidural abscess, spinal subdural lymphoma, and spinal cord abscess. Just briefly keynote that it is a rare condition with high mortality, high morbidity and mortality up to 5%, with the average age in middle age, most predominantly in male population. When we speak about clinical picture, we can see the red flags, dominantly back pain, exacerbating back pain, fever, and neurological disturbances, followed by spine tenderness and sweats. Also followed by comorbidities, diabetes mellitus, hypertension, IV drug abuse, chronic failure, or alcoholism. Usually they are set at the more than 50% interradical part of the spine, followed by lumbar and at least the cervical spine, and most predominantly more than 80% in posterior part of spinal canal. Source of infection is wide, but hematogenous direct extension, but more than 50% patients, we don't know the source of infection. How it's work, pathogenesis mechanism is with the direct compression of spinal cord or vascular occlusion due to septic thrombophlebitis. When we speak about the treatment of spinal epidural abscess, we can see that there are still controversies, but we can divide it in two ways: medicamentos for treatment of systemic manifestation of disease. The first successful treatment of multiple patients was reported in 1992, and the surgery mostly with the dorsal posterior laminectomy and the compression. But what is the mainstay of the treatment and gold standard up to now, followed by most studies and researches, is urgent surgical decompression and followed by systemic antibiotic use. But due to heightened awareness of disease, more availability of MRI and other radiological investigation, also with the wide usage of antibiotics, we can say that for today, high priority is to find the significant factors that allow safe usage only of medication of a source or conservative way of treatment. Relative consensus was done that patients with acute neurological deficit, spinal instability, progressive deformity, and failure of medication treatment require surgical approach. When we see these studies and the result of these studies, we can see that from ADOA and ARCO, early surgical decompression followed by antimicrobial therapy versus only antimicrobial therapy, there was no difference in clinical outcome. Also, that confirmed ARCO and colleagues. But from Patel and Kim, we can see that they found that 4 parameters that predict failure of medical management, that some sort of comorbidities, diabetes mellitus, and the high level of inflammatory parameters, multi-resistant infection, and neurological impairment that goes through 4 phases. We can see through the literature there are several algorithms that are managed for the treatment of spinal epidural abscess, but the main and key point of whether we treat patient with conservatively or operatively, it's a neurological deficit involving spinal cord, also with assessment of additional risk factors. We can see 3 of them that we use usually in our everyday practice. I will now present some of our cases and what we have done in that situation. A female patient, 57 years old, but all of patients that came to us had excruciating back pain with radical distribution, more usually in 1 month, forced supinate position, and no fever, no bladder disturbance, and GMS and neurological assessment of muscle strength was usually disabled due to excruciating pain. The inflammatory parameters were high, and this patient was really obese with other comorbidities. So we decided to, according to this algorithm that we use, we decided to operate and evacuate the epidural abscess, which showed in macrobiological analysis the Streptococcus faeces. So we treated this patient for more than 1 month. The recommendation, according to literature, is to treat them 4 to 6 weeks, but in some cases, due to prevent of osteomyelitis, it's a recommendation for 8 weeks. So the result after 1 year is really good. There was no sign of slippage of the disability of at the level of L5 to L6. She was independent walking and pain-free patient. Another also female patient with excruciating pain, the similar clinical picture with a fever, with no elevated level of inflammatory parameters, but positive Rose-Bengel test, accompanied with the other comorbidities. So we also, according to this algorithm, we also decided to operate it, but we didn't find any purulent content in epidural abscess. We followed by this antibiotic therapy, and 6 months after that, also the MRI showed a good result and regression of this content in the spinal canal. Another case was a male, 30 years old, similar to 2 weeks clinical picture of back pain, fever, no bladder and bowel disturbance, no signs of motor deficit in lower extremities, no comorbidities, but high level of inflammatory parameters. In hemoculture, we isolated Staphylococcus aureus, and on MRI, we confirmed epidural spinal abscess from T12 to S1, combined with spondylodiscitis L4 and L5. So according to this recommendation from Curry, because of involvement of extensive length of the spinal canal, we didn't do any surgery. We treated this patient conservatively, and after 3 months, we had pain-free patient with MRI after 6 months, who was like this, really good resolution of epidural content. Also, in this patient, I don't see here, I think 50 years old, also with excruciating neck pain, with no assessment of real neurological status due to pain, high level of CRP, and the MRI show epidural spinal abscess from C2 to T3, and accompanied with spondylodiscitis, and accompanied also with prevertebral collection of from craniocervical junction to C6 to C7. Also, according to this recommendation, we didn't treat this patient with surgery, but we stayed on conservative treatment for more than 8 weeks. And at the end of our presentation, I have, as I said at the beginning, 2 questions for audience and more experienced neurosurgeon, because usually every patient that came to us was accompanied with the pain. And as we said at the beginning, neurological status was something that we took like key point to decide where what to operate or stay or conservative treatment. And I don't know, is it a pain significant and sufficient indicator for surgical treatment with additional evaluation of other parameters? Because it's always mimicking a real neurological status. And also another question from the last one case, since we saw this study from 2023, we can see that normal diameter of spinal canal at the level of C4, C5 is 12 millimeters. The recommendations to surgery is more than 2.5 centimeters. What I'm asking now, are we so comfortable to rely on the radiological recommendation, or the neurological status is still basis of our decisions for the treatment? And another question, whether in this case, whether surgery prevent potential instability, or it will develop regardless of the form of the treatment. I hope that I will get some kind of answer. Do you hear me?
Yes, we hear you. Thank you, Dr. Fahrudin and Dr. Anes, who prepared this lecture. Let me just introduce my colleagues to Professor Kato. Dr. Fahrudin and Dr. Anes are young neurosurgeons from Zenica city, which is close to Sarajevo. They have a great team of 5 neurosurgeons as well as 1 resident, and they have a very good center, and we have a great collaboration all together. So if there are any questions from the audience, please ask. Yeah, this topic is quite frequent nowadays, since we have a lot of immigrants coming through the Bosnia for the Western Europe, especially with some tuberculosis as well. Okay, if we don't have any question, we may proceed with the next speaker, Dr. Ashish Kumar. You are here. Please unmute yourself and you can start with your lecture.
Thanks, Adi, and good morning, good evening to everyone from around the globe. It's night here, but I hope you are able to clearly comprehend my voice. And if there are any concerns, please let me know. I'm going to share my screen.
We don't see your screen yet.
Yes, I'm trying. Can you see my screen now?
Yeah, we see it. You can proceed.
Okay. All right, thank you, everyone. Today, I'm going to speak about some tips and tricks of endovascular management of aneurysms. I work at the University of Toronto in Canada, and my initial training has been in India. So I started my career as a hybrid vascular neurosurgeon, and now in Toronto we are we run a service we call as neurovascular surgery, where we basically combine open vascular and endovascular treatment of aneurysms and vascular disorders. So I would like to invite, if anyone wants to come for an observership, please do contact me directly. So today's learning objectives will be to recognize the intricacies involved in endovascular management of aneurysms, identify some key tips and tricks in the aneurysm treatments, and then list ways to avoid complications during endovascular management of aneurysms. I'll be speaking only about endovascular management today because otherwise it's very difficult to cover the open vascular and endovascular in the same talk.
So endovascular management of aneurysms has changed a lot during the last decade or so. This was a literature review in 2019, which compared surgical versus endovascular management of ruptured and unruptured aneurysms, and what are the true indications. So these indications are now considered as soft indications. There are many devices or there are many surgeons across the world who will not consider these factors as the definitive factors for treatment of endovascular or open surgical management. But traditionally, endovascular treatment is considered for aneurysms which have narrow neck, especially less than 4 millimeters, or the aspect means that the dome and the neck ratio is more than 1.5. Aneurysm diameter less than 15 millimeters. Again, this is a soft indication. Now we are treating aneurysms which are more than 50 millimeters too. Age more than 50 years, because generally surgeons consider that young patients need a more definitive treatment. That's why they tilt towards open surgery. And those who are able to maintain diligent follow-up. I'll say this is still true. As one of my patients who was not able to follow up, he said, like, we want more definitive treatment, and then the patient went for open clipping surgery. Now, when we compare to the open surgery, wide-necked aneurysms, those are the contraindications for endovascular treatment, becomes the indication for open surgery. Essentially, open surgery can be done for all anti-circulation aneurysms, those who are wide-necked, aneurysm diameters more than 15 millimeters, very small aneurysms, and we'll talk about that afterwards. Complex neck anatomy with a branch or perforator arising from it. I think this is very important, especially in the region of MCA, where you are not finding a very simple side branch aneurysm. When there is a complex neck anatomy and there is a branch coming from it, open surgical clipping is preferred. Fusiform shape, again, in my opinion, fusiform shape has changed now. Fusiform shapes go more for endovascular management of towards endovascular management, and usually in the form of flow diversion. These aneurysms are treated in today's era. Evidence of intraluminal clot. Again, yes, this is an indication for open surgery because you don't want to coil these aneurysms, as when this clot dissolves or disappears, your coils may become loose and the aneurysm will have a recurrence. Rupture status, I don't think so. That depends on open or endovascular treatments, and it more depends on the morphology of aneurysm. So to be very precise, I think these indications are rough boundaries of each treatment modalities, but I think there is a significant crossover between endovascular and open surgery. But one thing is for sure, that if the patient is able to follow up, and if there is no major branch or perforator coming from the dome of the aneurysm, I think most of the aneurysms are going towards the endovascular treatment here as per the patient's choices. So what I consider as difficult and tricky aneurysms, and I'm talking about these today, not the regular aneurysm which we treat by endovascular treatment. I think these are the three broad categories. If you ask me about endovascular treatment, we consider these as tricky, as those aneurysms which are wide-necked, those who are small and ruptured, and those which are large, giant, or dissecting. So we'll see specific cases one by one. So what about wide-necked aneurysm? So as we saw, anything above 4 millimeter is considered wide-necked. And now there are many techniques through which you can actually treat these aneurysms. So this does not become an absolute contraindication or indication for surgery versus open surgery. There are various tools at our hands, like a balloon or a stent, which can actually bridge the neck, and you can still coil embolize the aneurysm. There's another method which is called as a dual microcatheter technique, which can also help to occlude the aneurysm without the use of a balloon or a stent. So what is dual microcatheter technique? It's a well-recognized technique from many years before, where you actually put two catheters, as you can see here. You can actually insert two catheters and coil from both the catheters so that the coil mass remains stable and doesn't occlude the side branch. So you can see this is an aneurysm which is a complex anatomy, and you can see this branch which is coming from the dome, and you want to make sure that when you coil, you don't occlude this branch. Otherwise, the patient is going to have a stroke. So when you put two catheters rather than one, these coil loops, they tangle in between them and make sure that the coil mass remains stable. Otherwise, if it's only one catheter here, you keep on coiling and the coil mass will slowly come and occlude this vessel.
However, when there are two coil masks, as you can see in figure F here, they interact with each other, and they make sure that the coil loops are staying above the dome and clear of the branch which is coming at the base. So this is a very good technique, which is not very commonly used, but once in a while, if you see a wide aneurysm like this, you will know its utility. For example, this is a patient who was a 75-year-old female, presented with sudden onset headache, GCS was 7. The CT showed extensive subarachnoid hemorrhage. Then when you see the runs, you can see a large PCOM aneurysm with a fetal PCOM coming from the neck. So when you see this large aneurysm, you will see either use a balloon or you can use a dual microcatheter technique. Of course, the patient has a ruptured aneurysm, so you will not use a stent because it will need a dual antiplatelet therapy. But when you use two microcatheters, you can see this is our guide catheter on the left, and you can actually see two microcatheters going right into the aneurysm, and this is in process of coiling. So what happens is when one catheter, which is forming a frame of the coil, the second catheter actually can fill the coil. So the main technique has been, this is a very good video which is available on neurosurgery website, and it shows the utility of dual microcatheter. So the few tips and tricks when you're using two microcatheters to coil the aneurysm without a balloon is that you keep two catheters at different parts of the aneurysm. So one catheter goes deeper and the other catheter remains shallower. Or if you are looking into superior inferior parts, the one catheter remains up on the top of the aneurysm and second catheter goes on the inferior half of the aneurysm. You put a large framing coil from first catheter and do not detach it till the last coil is inserted. And that provides a frame through which you can put like multiple small filling coils via the second catheter. So these two catheters and the coils, they interact with each other in a way that both coil masks remain stable and they don't move towards the neck or the parent artery, because our goal is to tangle the coils to achieve stability. So this is a very good technique if we have a wide neck aneurysm which is going in two different directions, like superior inferior, or which has involved a significant main branch like a fetal PCOM, as in the last case. The second tool which you can use is the use of stents. As you can see on the left side, this is a Neuroform Atlas stent, which is a laser cut stent. It does not have any flow diversion capacity. It just provides this framework or scaffold to make sure that the aneurysm, we coil the aneurysms and the coil mass stay in the aneurysm, does not come into the parent artery. We'll see an example of a 32-year-old patient, grade 1 SH. Patient had a chronic IC occlusion. And if you see, this is a posterior circulation. Actually, this is the basilar top. And this is the PCOM, which had multiple aneurysms along with it. And these are called as flow-related aneurysms. In the 3D, you can see these are the SCAs coming from the base, and there are two basilar top aneurysms. And you can see the PCOM going towards the anterior circulation that has an aneurysm too. So for these, usually stent-assisted coiling will do well. These are unruptured cases. So, sorry, this was a grade 1 SH case because this was a posterior circulation, has a very small trickle blood. So at that point of time, the approach for these is to make sure that we treat it with the stent and the coils to make sure that the patency of the fetal PCOM is also maintained. And these are posterior circulation aneurysms. They are generally preferred and treated with endovascular treatment. And and it's one of those rare cases where even if there is a grade 1 SH and if there's a small amount of blood in the brain, you will load the patient on dual antiplatelet and still do the coiling. And you can see the stent here and two aneurysms which are actually coiled. So tips and tricks when we are talking about the stents. We try to avoid stents in ruptured aneurysms, but as you saw in the last case, if you are dealing with a posterior circulation aneurysm with a fetal PCOM and you want to treat all the aneurysms together, you may have to use a stent in a ruptured situation, but this is an exceptional situation and rare circumstance, I will say. Laser cut stents, Neuroform Atlas, are better than braided stents, but sometimes you can use braided stents to achieve some sort of a flow diversion as well as neck support for the coils. Oversize or elbowing is very key at the wide necks. If you see you're dealing with a wide neck, you can actually oversize the stent to cover most of the neck. And when you're doing deployment of the stents, I would also avoid kinks while deploying because they can thrombose if the lumen of the stent is kinked. We can measure the length in the vessel of the vessel diameter very carefully because you need to oversize it slightly so that there's no difference between the stent and the vessel wall. And as if you are dealing with a tortuous anatomy, usually always go for a longer length of stent because these stents will come back and foreshorten when you are dealing in a significant tortuous vessel. Now, the third most established way of treating wide neck aneurysm or a small aneurysm in a ruptured situation is balloon-assisted coiling. Most of us know about this, but sometimes you are dealing with a very, very tiny aneurysm. This is an ACOM aneurysm in a very young patient. But we opted for the endovascular treatment. And when you are looking at these small aneurysms, you can actually still go through multiple small channels and pathways, get your working projections right, and you can coil them, these aneurysms, if you are supposed to treat them with endovascular treatment. Again, when we are talking about open treatment endovascular, there's a lot of dilemma, but it also depends on a lot of patients' preference. So sometimes if they prefer that they have to treat it via endovascular means, you can treat it with the help of a balloon, but because you are treating a very, very small aneurysm, what you need to do is you need to make sure that you use balloon. As you can see, the balloon is in ACA, and you can put a small catheter, which is at the neck, and you can still coil them. So these are very intricate cases and will need a lot of technical competency, but with time, when you start to move from larger to smaller aneurysms, you can still achieve them without causing any complications. So balloon inflation, deflation, you have to be very careful what you are seeing. Sometimes you don't see the contrast well and you can inflate more and can cause rupture of the vessel, but you have to be very careful in your haptic feedback of inflation against any vessel, especially if you're working in a small vessel. Overinflation and underinflation should be avoided. And if coils are unstable after deflation, I usually put first coil and deflate the balloon. If they're unstable, then you actually inflate and keep multiple coils. The idea is to keep the tangle safe. And once you tangle all the coils, they generally do not come into the parent artery. So you inflate and you push multiple coils under the single inflation of a balloon. Still, you want to make sure that you keep the balloon inflated for not more than 2 to 3 minutes. The idea is to avoid the prolapse of coils in the parent artery, and therefore balloon is a very good tool. Now, coming to small ruptured aneurysms, as we saw in the last case, they're very tricky, and there is a lot of research available on endovascular treatment of very small aneurysms. Normally, this will be an open indication for open surgery, but again, in today's world, patient preference is really something which decides also the part of the treatment. So if you see here, this meta-analysis actually has clearly shown that very small aneurysms treatment for endovascular management is feasible and effective, but the risk of peri-procedural rupture is higher than the report for the larger aneurysm. So of course, you are dealing with a very small case, very small volume of the aneurysm, and therefore sometimes there can be in the combined peri-procedural mortality and morbidity is slightly high for endovascular arm. That's why normally people prefer an open surgery for these, but if the patient wants it, you'll have to sometimes do the endovascular procedure. Something like this is a 54-year-old patient who had a WFNS grade 3 SH, and you can see a small aneurysm just at the proximal origin of the MCA and ICA bifurcation. This is a ruptured situation. Again, you use a balloon, and when you use a balloon, you make sure that you have a proximal control. And if suppose you are dealing with a small aneurysm and if it ruptures, you can immediately inflate and control. So you can see this is again a similar case. Balloon was kept distally and in the MCA, and there's a second catheter which comes and coils the aneurysm and preserve the branch which is coming from the neck. So another case, 61-year-old patient, anterocommunicating artery aneurysm. Patient is already on dual antiplatelets when patient ruptured, and it's a small 3 millimeter wide neck aneurysm. In this case, again, you can use a stent and you can use another catheter to coil the aneurysm. The stent will make sure that the coils remain in the small aneurysm, and as patient is already on dual antiplatelet therapy, actually it helps you in a way, and you can immediately go and deploy the stent and coil the aneurysm as well. So what are the tips and tricks of small aneurysms? I'll say microcatheters you can coil these aneurysms with catheters just at the neck. Avoid going completely inside the aneurysm, because then the coils can rupture through a small aneurysm. So we usually coil them. If we have to coil them from the neck. And we use our coils to go inside and make sure that the catheter stays at the neck. And always use a balloon. Small aneurysms, always use a balloon as an insurance policy in case of a perforation. And again, haptic feedback of coil and the catheter is very important. You can feel the resistance when you're pushing a small coil through a small aneurysm. And we never force a coil, and you can always see that if the coil is having a squiggly appearance or the catheter is pushing back too much, that means the resistance is very high and you have to relax the whole system and again try. Again, keep an idea in your mind that you may have to abort, and your patient will have to go to open surgery. So whenever I speak to them, I tell them that, okay, if you want this, we can try, but if it doesn't work, patient will need an open surgery. And most of the patients will actually like that. So these are the tips and tricks to avoid a perforation in a small aneurysm, but they can be done. Now, lastly, flow diversion. I think this is a complete topic in itself, but as I said, the complex aneurysms like large, giant, dissecting aneurysms can be treated with deployment of these stents, which has very, very high metallic surface area, and it basically alters the hemodynamics of the aneurysm and generates clot formation. For example, large aneurysms, again, posterior circulation. This patient presented with diplopia and ptosis. So you can actually see here, this is the posterior circulation and the PCA is going around it. And when you see that, you also see a small SCA coming from the dome of the aneurysm. So they are very tricky to treat. Usually flow diversion becomes a good treatment for them. So you can see the small catheter going in the PCA and flow diverter being deployed in the basilar top. And when you actually dealing with such a large aneurysm, usually all the surgeons prefer to put some loose coils to also secure it and prevent too much formation of clot, because sometimes that can generate an inflammatory response. So if you are dealing with a large aneurysm and you're using a flow diverter, it's a double insurance policy to put some loose coils in to make sure that the thrombus is not significantly generated and it's not a large volume, because sometimes if you just flow divert these aneurysms, sometimes the whole aneurysm will clot suddenly and it will release some inflammatory cytokines, and you can see a rather contradictory increase in size and inflammation and rupture of these aneurysms. So generally, the idea is to keep flow divert the basilar aneurysm or a large aneurysm and put some loose coils in it. This is again an indication of flow diverter when you basically treat a patient with in a emergency situation with interval coiling. This is an anterior choroidal aneurysm in a 70-year-old patient. You treated them, and after a few years, you see there's a recurrence. Then these are relatively easy. You don't want to go into the aneurysm and coil it again because you want to preserve the anterochoroidal artery. And in these situations, as you can see, a flow diverter is a good choice because you have actually treated them many months or years ago. And when you see a recurrence, you can actually use a flow diverter. You can see a flow diverter is completely deployed, and you are covered the base of the aneurysm, and you can see the stasis after the flow diversion is done. Again, this is an example of typical paraclinoid aneurysm. You can actually see the flow diverter being deployed. This is the paraclinoid aneurysm. Of course, the option is anticlinectomy and clipping of aneurysm if you're doing the open route, but if you're using endovascular treatment, you can deploy a flow diverter across the neck of the aneurysm. You can see the flow diverter is being deployed. You just need one catheter, and you don't need to coil the aneurysm because it's a small sized aneurysm, so the clot formation will not be significant. So we just deploy a flow diverter across its neck, and you can see the flow diverter being deployed. And once the spin is going around, you can see the flow going into the aneurysm, and you can see stasis in the aneurysm also. So again, tips and tricks for flow diverters. Again, it's a big variety of flow diverters available in the market, and you have to make sure that you use the right kind of flow diverter for the right patient. Sizing is very important, so give your time, give a lot of time on 3D calculations, measure the inner diameter proximally, the landing zones distally, so you choose the right flow diverter of right size. Dual antiplatelet must be in the blood for a minimum of 5 days. So if these are unruptured situations, we ask them to start the dual antiplatelets 5 days before the procedure, and we avoid using it in ruptured situations by any chance. You have balloons, you have dual microcatheter techniques to coil those aneurysms if you are going the endovascular way. If the flow diverter is impossible and the vessel is fusiform and dilated and it can be sacrificed, parent vessel sacrifice also becomes an option, especially for vertebral artery aneurysms when there is a dominant vertebral artery on the other side. Again, when you're doing these, you have to look for thromboembolic complications, make sure you you have heparinized the patient well, because they are very prone to generate clots and can cause thromboembolic complications significantly if you are not focusing on the heparinization or the activated clotting time and you're not observing them. So always monitor your activated clotting time. We call as ACT, we target between 250 to 300, and that's an important thing to look out for. And whenever you are actually deploying them, there's a lot of push and pull involved with flow diverters so that they open very well, because they are very high metallic component stents. So you have to make sure that your catheters have no resistance and they are on the inner curve of the vessel and there's no tension in the system, because if there's a lot of force you are trying to push through it, the stent won't open. And if the stent doesn't open and deploy it, it will clot the whole artery. So it's very important to go slow and slow. And usually when you learn in your intervention, flow diverters are the last milestone, I will say, which you learn, and then you deploy the flow diverters at the end of your fellowship if you're doing a fellowship. But that tells you that you understand the forces which are involved in a catheter when you are deploying a stent. So you always be mindful of that, because once you deploy it, you cannot go back and retrieve it. So to conclude, I will say, if you are treating a patient with endovascular treatment, simple coiling almost always works. So whenever you see a aneurysm with a small or wide neck, you know that you can treat them with simple coiling. You can use dual catheters to make sure that you preserve the parent artery. You can use balloons in a ruptured situation, stents in an unruptured situations. As I said, rarely if you are doing the posterior circulation, you can use a stent there as well. In those cases, we just load them 3 hours before the surgery. You avoid using flow diverters in main vessels, like which have bifurcation. That's why, as surgeons, we do not use flow diverters in the ACOM region or in the MCA region, because when you deploy a flow diverter, there's a high chance that the branch which you are covering can thrombose. You can avoid flow diversion in perforator-rich area like M1 territory. Again, these are indicated for only proximal ICA region. In an unruptured situation, but if you have to deal with distal aneurysms, open surgery becomes the main choice. And again, most important is long-term follow-up is mandatory. So when I see my patients, I tell them that this will require every 6 months MRI, and if they are able to follow up, which most patients are, you treat them in endovascular treatment. And when I am discussing about open surgery, I say this is a definitive treatment, does not require that long follow-up, but the endovascular treatment will require long-term follow-up. So those who cannot come for regular follow-ups, I would avoid using endovascular means to treat the aneurysms. So this includes a lot of discussion with the patients. So always, discuss all the options before. And if you choose to use endovascular treatments, these are the special, considerations which you always keep in your mind. Thank you so much.
Thank you, Dr. Ashish, for wonderful lecture. We have one question from the audience from Indonesia, Dr. Aditya Saihada. How do you think about packing density in coiling aneurysm? Does it really matter?
I think it's a very important question. When you are clipping an aneurysm, you almost always know that the aneurysm is completely excluded from the circulation. But when we are talking about the endovascular arm, if you are doing an unruptured aneurysm, I think you tend to coil more definitively. While you're using a ruptured aneurysm, you have to make sure that it is sufficiently coiled so that there's no flow towards the dome of the aneurysm. If you see for example, a Murphy's tip, or you see a daughter sac from an aneurysm, that area has to be coiled perfectly. And in fact, the idea is always to coil the aneurysm as best as you can, but you also have to see that your coils do not prolapse into the main artery, and you pack it more definitively. So if you can pack it more definitively, obviously you keep on coiling. So we start with the framing coil and keep on coiling till the time there's no flow into the aneurysm. But sometimes you are not able to do that. And as I said, showed in my last case, if you do an interval coiling, you coil the ruptured part of the aneurysm or the daughter sac, and you bring the patient back again to flow divert him later on, when you can actually keep the patient on dual antiplatelet therapy. So the coiling density matters, and the more denser you coil, the chance of recurrence, the chance of aneurysm coming back comes down significantly. But again, that may not be possible in a ruptured situation, but our elective coilings, the idea is to pack it very densely.
Thank you. Just one more short question. What is the minimum packing density?
Generally, if they are very like, there's some softwares to see 40% is say like, okay, you can get away with it, and once we see 40% density, we think, oh, we are leaving 60% of the aneurysm behind. But when you actually go through those softwares, they can you can see that you have coiled very well, but if you use those softwares to see your coil density, it will still show you 40% to 50% density of packing. So I'll say like minimum is obviously 40 to 50%. But these are because of the softwares. But in my opinion, I don't use those softwares. I use visual, inspection and how the aneurysm is getting thrombosed when you are putting the coils in. As long as I see there's no contrast flowing into the aneurysm, then at that point of time I stop. And again, these softwares will indicate that you have coiled like 60 to 70% of coiling density. Achieved 60 to 70% of coiling density, but that is good enough. There's no contrast flowing into the aneurysm. And we follow that with MRAs in 3 months, 6 months, 1 year. That tri-step follow-up becomes important.
Okay. Thank you, Dr. Ashish, for your answers. We should proceed for our final lecture by Professor Arnautovic, who doesn't really need any special introduction. He is a great worldwide famous expert in neurosurgery, and we had the lucky in Bosnia and Herzegovina that he was our teacher and mentor of many of us here. So Professor Arnautovic, please proceed with your lecture.
Good morning, everybody. Can you hear me and see my screen?
We can hear you and we see your screen.
Well, first of all, thank you very much, Professor Kato, Professor Omerhodzic, for this kind invitation. I consider Professor Kato my mentor, and I admire her work as a patron for young neurosurgeons and education around the world for many, many years. Although she's still very, very young, she is our role model how the education in the world should be. It's 4 o'clock in the morning here in Memphis, Tennessee. It's really early, but really excited to be here among you and see so many young neurosurgeons from Bosnia and Herzegovina, from Asia and Africa. I want to greet you on my behalf as the chair of committees of World Federation of Neurosurgical Societies. And, our goal is to have you, young neurosurgeons, better than us, because if we did not achieve that in our mission of education, we did not achieve much. So I'm going to talk today about one of the many topics that I've been involved throughout my neurosurgical career, blastomas. I would like to, I have no disclosures for this talk, except for being holding some of the officer position in neurosurgery. And I would like to acknowledge my fellows and young neurosurgeons and colleagues who really contributed a lot for my many publications that I did on the subject. And I would like first to go over this review of all published cases between 1985 and present, that we demystified all the knowledge about hemangioblastoma that has been so far published in the literature, and then over some of my cases and some of the case examples. As you all know, hemangioblastomas are rare tumors representing only about 2% of intracranial tumors and about 7 to 8% posterior fossa tumors. They are believed to be more often in males than in females, and they may be as a single tumors sporadically in the general population, but multiple tumors more commonly associated with von Hippel-Lindau disease. As you know, von Hippel-Lindau disease is associated with mutation on chromosome 3, and they go with multiple other tumors such as renal cell cancer, retinal angiomas, adrenal gland or pheochromocytomas, kidney cysts, and so forth. And we need really to do thorough evaluation of all these cases because, for example, retinal angiomas can cause blindness or damage of vision. So when we go through the list, these are published cases, supratentorial, infratentorial spinal cord. These are the years. You can see that overall, over the years, the trend of publication has increased, which is obvious. And then when you look by countries, obviously, United States leads the pack, followed by Japan, Germany, and China. Now, it's interesting to know why is this? Is this because they are more common there in the population of these countries? Is there some regional, racial, or other component, something that needs to be looked into? And again, as you see here, most commonly they are published in, the articles are published in Asia, obviously, and then followed by North America and Europe. Now, when we look in distribution of age, gender, and sporadic versus VHL, you can see that the incidence varies. For example, von Hippel-Lindau is more common in spinal cord in von Hippel-Lindau than sporadic, while situation is completely different in supra and infratentorial von Hippel-Lindau. Median age is roughly the same. The location, obviously, you can see here for each location what are the most common locations, and obviously they're evenly distributed in supratentorial, whereas cerebellum most common in the infratentorial, and then as you can see here, cervical spine most common in the spine location. The symptoms are quite different, obviously, but increased intracranial pressure, one of the most dominant. Distribution of hemangioblastoma tumor types. You know, everybody thinks that hemangioblastomas are tumors with a cyst surrounding, a nodule surrounded by the cyst, but it's actually not the case. Most common cases, as you can see here, are solid tumors. So I think this is one of the things that we discovered in our review that kind of demystifies that most common these are tumors with nodules and cysts. These are the staining proteins for diagnostics. Again, these are the most frequently used. S100, Vimentin, NSE are most common, and CD34, CD56 most common stains. Resection rate, this is also interesting. It is good, but it's not perfect, you know. It's roughly 80% or a little bit over, but it's not 90 or 100, so we need to do a better job in gross total resection. Now, one of the bad things about this tumor is high blood loss. As you can see here, it is in cranial locations close to 600 to 700 cc's, in spinal location also very high. And these are the other complications that occur. As you can see here, infratentorial location, very common. Almost every other patient has a complication. Better on this front. Mortality, as you can see here, 4%, 10%, 5%. So mortality is not low. 1 out of 10 patients in infratentorial locations will die with this problem. So the number of publications, you can see that they have significantly increased in the past 21 years. Most articles published, as I said, in Asia and Europe. However, US leads the number of publications. Most frequently, these tumors occur in 5th decade of life and in men. Sporadic tumors are more common in cranial locations and von Hippel-Lindau. Most patients undergo total tumor resections, which results in favorable outcome in most of the patients. Complication rate is ranges between 7 and 40%. Both are highest in infratentorial location, and surgical treatment, as is shown, remains challenging for neurosurgeons. Blood loss is double in cranial locations. I'll just show some of the cases from my series that I also published. This is a case of solid hemangioblastoma in the right cerebellar hemisphere. This is 53 years old lady who presented with balance problems. And you can see here, this is the right side, obviously. This is right cerebellar hemisphere. You can see here, we are going around the tumor much like AVM to devascularize the tumor and keep this big vein you see on the left side of our screen, keep it intact, so coagulated in the end. Otherwise, you would have tremendous bleeding. You need to be very careful and do strategic coagulation and devascularization of this tumor. And you will see that over time, as you progress with tumor resection, you will come into a situation that you have a fairly significant bleeding in some of the locations while operate this on this tumor. You see some of the blood vessels are extremely large and vascular. At the end of surgery, you come and approach to final devascularization, coming close to the tentorium. You can see here why sometimes blood loss can be high, but you see here, if you do it in a proper way and devascularize in a systemic fashion, the blood loss is really not that high. Coming to the end of surgery and removing the tumor, these are the final blood vessel contributions. You see here, I'm using controlled Yashar-Gill suctions as with all intracranial cases. I believe that my personal opinion that using controlled suction in the intracranial surgeries is almost like malpractice, because you have to control your suction, especially working on aneurysms, blood vessels, or fine cranial nerve structures. You see here the end of surgery, and here you can see the gross total resection of the tumor in the patient. Another case, this is a cystic and solid combination. So patient has a cyst in the center of the tumor and then solid component in the wall of the tumor. And you can see here gross total resection. Again, this is different type of hemangioblastoma. This is a typical type that we always think about when we know about hemangioblastomas, which have a nodule and a big cyst. So all what we need to do is resect this nodule and the cyst collapses, and this is the end of the story. Another case of solid hemangioblastoma. This guy is a preacher here in neighboring state of Arkansas. Very nice gentleman, presented with severe balance problems, and he presented with this fairly relatively large lesion. More it's swelling around the tumor that's causing compression balance problems. And you can see here, again, gross total resection, similar technique as I showed in the previous case. Another case, solid small. This is lady with 70 years of age, retinal condition that she has been followed. She does not have von Hippel-Lindau, but they thought it may be melanoma metastasis. So we operated on her and encountered hemangioblastoma, this gross total resection. Spinal cord locations. This is a brainstem tumor with nodule and the cyst, and you can see here adjacent to the vertebral artery, and patient presented with inability to swallow, quadriparesis, and very important in these patients, especially hemangioblastoma, to follow them for life, von Hippel-Lindau, to follow them for life, because they do tend to develop hemangioblastomas subsequently, sometimes year or years after surgery. I'll show this case. This is after exposure. This is the nodule, and you can see here my resident is helping me release the adhesions, open the arachnoid membrane. You can see here C2 nerve root. And most important things in this is, again, to keep this vein intact and to open at the junction the PL spinal interface, as I'm doing here. So you don't want to go into the spinal cord, but also you don't want to go in the nodule. So you need to find this perfect plane between the two and then slowly go around. Again, leaving the vein till the very end. You see here, there is a small perforator. Vertebral artery is just here on the left side, which is rostral. And here we are dissecting this perforator. This is tedious job. You need to go slowly because one perforator and you may end up with disaster in the brainstem while this is resected. Progressing, going around the tumor, as you can see here, very avascular surgery if you do it in the right plane, and it can be a disastrous bleeding if you do it, if you enter the nodule prematurely. We'll come closer to the vein as we go around. As you see here, again, fine progressive length Yashar-Gil bipolars. And you see here, this is very important. You see the tip of this suction is a traumatic suction, protected suction that Professor Yashar-Gil invented for us. And again, I see benefits using this kind of instrument with controlled manner. And then we're coming to the end. You can see here almost finished, coming to that vein, which we are now coagulating at the very end and removing the tumor. This is a final view. You can see here cerebellar area. You can see here brainstem, obviously arachnoid membrane, and tumor will come out in just a second. This is overall full view. And here is the cavity that is collapsed after the surgery. Postoperatively, you see the cyst is collapsed, and patient in the OR, in the ICU, morning after surgery, is able to swallow. Here is she eating a sausage for her breakfast the next morning. I did not wait swallowing study because I was sure that the pressure that resolved in the brainstem would allow her to swallow normally. This is the final case. This is a gentleman that is a plumber. He presented with urinary incontinence, 30 years old, T11 hemangioblastoma, cystic with nodule. You can see large nodule, and then swelling in the spinal cord going all the way up to the craniocervical junction. And just to show a few important steps in the resection of the tumor, here is exposure. And once you open, you don't see much other than big vascular nodule, and you don't want to go into that nodule again. You will see in my cases how there is no significant bleeding, because it's all knowledge about the anatomy and starting the dissection from away and then going slowly around this vascular lesion, preserving the nerves with spinal cord monitoring of MEPs, SSCPs, and D waves. You can see here nerves on the right side, and we have to be in the plane between the spinal tissue and the vascular tissue. Here you can see exactly it's leading me into this plane and starting the dissection on the right side and now on the top of this lesion. And also note here the vein. This is the main drainage vein. You want to keep it intact and till the very end. Go first after the small arterial feeders that are very important is to use intermittent coagulation and opening spring of your tips. You see here to develop the plane. You see right at the junction between normal tissue. And you see how with little irrigation and appropriate plane, there is 0% bleeding. Progressing nicely, now from the top to the left side of the lesion. Obviously, by doing this, the cyst eventually drains the fluid, clear fluid in it, and decreases the pressure, which further helps your dissection. And also, you can feel here how much tension there is in this lesion, and how much it releases with devascularization, especially with cyst drainage. Progressing further, here is the final devascularization of the top right part of the nodule. And I like to help microperis. These peris look huge under the scope, but these are actually microperis, which are obviously keeping your plane and maintaining it. Here, finishing from the ventral side of the lesion, removing the small blood clot that has accumulated, and closely monitoring SSCP. Oh, sorry. Just want to come to the very end. Here, as you can now see, that the nodule is almost completely dissected. There is a cavity, nice and glistening. You see how we did not get into the spinal tracts at all, and we preserved all the nerve roots intact. Here is the final part of the arterial feeders and the vein left for last for coagulation and resection. Here is the final view of the operative site. This is T11 level, just to remind you. And this is just a post-operative view. I like to use gel foam powder, indispensable with epidural bleeding and preventing epidural hematoma, which is one of the possible complications with this tumor. You can see here gross total resection, immediate postoperative MRI. And you can see here patient came for sutures, neurologically intact, and cyst completely collapsed, obviously all the way up. So I will stop here. I hope I'm staying on time, my allotted 12 minutes, and I'll be happy to answer any questions. Thank you.
Thank you, Professor Nautovic, for one more outstanding lecture. I would kindly ask Professor Kato and Professor Omer Hodzic to give a comment.
Okay, thank you very much, Canon. It was wonderful, great lecture, even at 4 o'clock in the morning. So you are so sharp. Just I want to ask the timing. Now, when you do the embolization, do you do the embolization for this the hemangioblastoma, or what is your opinion? And what's the timing in between the embolization and the surgery?
So first of all, for full disclosure, thank you for that question. And I enjoyed the previous presentation on endovascular treatment. In my department, we have seven neurosurgeons who are endovascular and open vascular neurosurgeons. So we have the best of endovascular. So we have that option. However, in hemangioblastomas, I do not use embolization because I showed you with precise technique. I really don't need it. And I'm afraid that with embolization, especially small compartments like a spinal cord, you would have a bigger or firmer tissue, non-compressible to dissect. So I personally don't use it. I don't have much opinion about it. And this is very rare tumor. So nobody has hundreds of cases. Everybody is somewhere in dozens with the big volumes. So, Professor, I don't use embolization personally. I don't think it's wrong, but I just don't have much experience. So,
Thanks. Thank you very much. So maybe Dr. Ashish.
Ma'am, can I ask one question, if you allow?
Yeah, please, Dr. Biswas, proceed with your question.
Thank you. Sir, do you consider pre-op embolization for the posterior fascial hemangioblastoma?
again, I did not. I have, as I showed, several cases. Blood loss stays below 100 cc's, and I did EMs. Many times surgeons that I learned from, Professor Evandro Oliveira, Professor Yashargil, Ali Krisht, my friends, my mentors for many years, don't use embolization in AVMs. Many people use. I don't say it's wrong, but I personally did not use for posterior fossa. As I showed, blood loss is really low, even with this very vascular lesion, if you precisely coagulate and take down these blood vessels. So I've been taught by my mentors that way. And again, I'm not saying it's wrong to embolize. I just didn't find much utility with embolization.
Okay. Sir, actually, due to audio problem, I could not ask a question to Professor Ashish Kumar, sir. But I want to take the privilege and ask sir a question, sir, if you allow.
Yeah, please proceed with your question for Professor Ashish.
Sir, when you use the double microcatheter technique, which guide catheter or distal access catheter you prefer for the navigation?
Thank you, Dr. Biswas. When we are using for any aneurysm, the most important part which we always focus is support, because your catheters are very small and floppy inside the brain. If you do not have a proper support, your catheters will not react the way you want them to react. So we call as one-to-one reaction. That will be not there if you are doing with the catheter way down in the neck. So normally we use a triaxial system, so something like a big neuron max or a guide catheter in the neck, then intermediate catheter, which is like which can be DAC 44, CAT 5, CAT 6, something which goes up to the cavernous, and then we use a microcatheter to coil the aneurysm, and this is for any endovascular treatment. If you're using two or single microcatheter, the access has to be, I prefer triaxial support. So I always have a guide and the intermediate catheter like CAT 5 or CAT 6. You can use Navian, you can use any other distal access catheter, and then you use the microcatheter in the neck. Gives you more support for any kind of treatment.
Comment, please.
Yeah, Professor Arnautovic, please proceed.
I want just to tell you, young neurosurgeons, we all love neurosurgery, microsurgery. I'm a microsurgeon. I'm a skull-based surgeon. But this is a great example how endovascular neurosurgery belongs to neurosurgery. In my opinion, it mostly belongs to neurosurgery, not interventional radiology, not neurology. I'm not saying they should not be done. I have in my department also neuroradiologists and neurologists doing endovascular neurosurgery. But it's very important to do these fellowships, finish them, have that armamentarium in your hands. Being a good endovascular neurosurgeon does not mean that you are a bad microsurgeon. It's complementary. It doesn't exclude one another. Same as with spine, Being a good spine surgeon does not make you a bad microsurgeon. This is crazy to think about it. It just enriches your neurosurgical armamentarium and brings it away from others, because we know how to deal with dura, with microsurgery, with all other things. We know how to take care of CSF leak and so forth. So we should embrace all these subspecialties. Young neurosurgeons should do fellowship, devote additional year or two in your training, because that's only makes you better, more comprehensive neurosurgeons. Because at this day and age, when there is attacks on neurosurgery with all kinds of insurance companies and everything else, decreasing population of patients, you have to have in your hands expertise for many different subspecialties. So I encourage all of you younger neurosurgeons to train, to get these skills and knowledges. And I think this is a great example. Dr. Kumar, you want to add this comment to this comment?
Thank you, Professor. I'm glad you said that, because when we are training our fellows and we ask them to be very open to both the approaches and both the techniques, it's exactly the same thing which we tell to them, that if you are doing both procedures, make sure that you have an open mind to choose the right approach for the right patient. And one particular thing, like if you're doing endovascular treatment, you do not become a worse microsurgeon. They are all complementary to each other, and you can easily change your approaches based on the morphology. I mean, that is something which is the philosophy of which I always believe, that neurosurgeons should be trained in both the techniques, so that you don't have you're not deploying flow diverters in ruptured cases in all the time. You are not using intervention way too far, because then that, okay, I can access this by some other way. So I think staying in the middle ground always helps, and I think we have that capacity as a surgeon as well as an interventionalist to decide where to go. I think that's a very important point. Thank you so much. I would just like briefly mention about the endovascular embolization of hemangioblastoma. Again, we do not perform it as well, Professor, as you said, because even for meningiomas, now the same question comes in. Like when I go to meetings and people say, oh, we embolized this meningioma, and I see there's a convexity meningioma, and they have embolized it. They say the blood loss becomes less, you can operate quickly. These are the solutions which are normally given, which I don't believe they are correct. Just because you have a tool, you don't want to use it when you don't want to use it. It's a convexity meningioma. Your microsurgical skill should be good enough to take care of the blood supply surgically. Same with hemangioblastoma. If you can access them directly, you do not want to put the patient at risk, because when you are putting these liquid embolic agents, they can go anywhere and you have no control on them. So they are very, very intricately placed sometimes. So and you can easily tackle them by surgical route much better than an AVM. AVM, some surgeons still prefer endovascular embolization, but because there are multiple deeper feeders. But here, hemangioblastomas, as you said, most of them are PL based. You can actually reach, if you dissect your planes wisely, as you showed in your videos, I think you don't need endovascular embolization, because the risk is too high for endovascular embolization.
Yeah, that's a great point. You mentioned meningiomas. I've done who knows thousands of meningiomas. I never embolized any one of them, because I learned how to do early devascularization and all that. But I had 2 cases of embolization by my partners who did embolization and said, okay, we'll do it next day. We embolize, and then they'll do the next day the resection. Happened to be on call, and in the middle of the night at 2 o'clock in the morning, I was called with patient herniating, because after embolization, you need to be very careful. If you do it, you need to do it, in my opinion, the same day, because if you wait another night, the infarction of the tumor happens, swelling increases, and patient may die. I had 2 cases from my partners. Then I thankfully saved their life, but it was not a pleasant experience to operate on huge meningioma in the petroclival area, at 2 o'clock in the morning. It's really, really bad idea. The other thing is, when you're mentioning here, and I'll take another few seconds just to say, people now do embolization of middle meningeal artery with some promising results and outcome. I personally think that it is always good to enrich our capabilities of embolization, especially are good for 90 years old who are bad surgical candidates for anesthesia, people recurrent subdural hematomas, But I think that borehole drainage remains the main treatment of this, because you do one borehole, and I have once in my career, I still take full course. Once in my career, I had to go and do it 2 times drainage, but 99% of the time you can do it. So use judiciously, know how to do procedures, but as you said, choose the proper solution for every patient. Thanks.
Thank you. Thank you. It was such a great discussion between the masters and Professor Omerhodžić. Maybe you can start with closing remarks of our webinar.
Yes. Adi, thank you. Thank you, Professor Kenan. As you are my friend and my teacher and of many neurosurgeons here in the region of Southeast Europe and in the world, of course, that was the nice lecture, really. And I know your Syria is one of the largest in the world of the hemangioblastomas, and you made a meta-analysis, which is also a contribution to the literature for all of us. However, thank you also for stand up at 4 a.m. I send you Weber message to be sure that you are awake. Only one question. We know that the hemangioblastoma sometimes we find the recurrence. Do you have this kind of experience and what to do with that? And on the other place, something, not always on the operative field.
So, good question. Good morning. I see a beautiful picture of downtown Sarajevo behind you, and I miss my hometown. I'm coming back soon. The recurrence, like any tumor, even meningioma is the most benign meningioma, you have to follow for life. I think that every tumor that you have taken out, the patient should be followed, even just once every 5 years, because there is always risk of recurrence, even with meningiomas, benign, schwannomas, whatever. Hemangioblastomas, I showed this lady that we did gross total resection of the nodule von Hippen-Lindau, and she's now about 4 or 5 years after surgery. And there is a small, I didn't show it, there is a small nodule in the cerebellum, de novo nodule, that is forming. Right now, it's not for surgery because it's only 1 or 2 millimeters, but I'm sure over the next few years it will grow, and I'll be going back and resecting it. So yes, you need to follow all the tumors. I never release them from my care, or if they move to another city, I tell them, hey, make sure in 5 years, go to your primary care physician, repeat the MRI with and without contrast, because there is a risk of recurrence.
Thank you. Thank you, everybody. Thank you, Professor Nautovic, and all the speakers today, Professor Dubovoj and Professor Kumar, and all the people, especially those young guys who organized this meeting under the cover of Professor Kato. I hope we will see each other again soon, maybe after the new year. Professor Kato has some ideas and we already talk about that. Do you want to say something, Professor Kenan?
Yeah, very important. Obviously, we have young neurosurgeons from Africa here. Make sure we have to show up in December in Cape Town. There is a World Congress there. I already bought my tickets. I'll be there. I know many of you will be there. Professor Kato, I'm sure, will be there. But make sure advertise. This is a great opportunity for networking, for exchange of ideas. So please do your best to. I know it's difficult to take time, and also it's somewhat expensive, but if you can afford to come, it'll be a great opportunity. Come to Africa, come to Cape Town in December.
Thanks. Professor Kato?
Okay, so thank you very much, Kenan, and all this, the participants and speakers. I think this is a very unique webinar this time. So the 3 continents, we can conjunction, and maybe we can have lots of discussion. And also each continent has many, I think, issues to be solved, I think. So in the future, maybe the ACNS with Professor Ibrahim, maybe we can have a conjunction with another continent, then we can have more. more extent some good knowledge and skills for YNS. And thank you very much for all speakers, especially Canon, such early in the morning in US. So we will see all in the Cape Town. Thank you so much.
Thank you.
Thank you very much.
Thank you, everybody. I think we can conclude today's session.
Thank you.
Thank you.
Bye.
Have a nice weekend.
Bye.
And keep in touch.
Thank you. Thank you. Tango, you want to say something? Okay.
She left.
She left?
Yeah.
Yeah, maybe she just hug us.
So, Kamalo, you want to say something? Because you will leave in 2 days.
Thank you so much. Yes, I'm leaving in 3-4 days. I just want to say thank you to all the mentors here, especially thank you to Kato Sensei, who accepted us to come and do our fellowship in cerebrovascular. So we are very grateful. And in my country, we are only 19 neurosurgeons for more than 95 million population. And yeah, so I came to do my fellowship. I'll be the first clipper in my country, if I go back. So yeah, thank you so much. We are very grateful, Kato Sensei. Thank you.
My best wishes. So maybe I think another Adi, you want to say something? Thank you very much for MC today.
Thank you, Professor Kato. As always, it was a great pleasure to moderate these kind of sessions. And thanks to all the speakers. I really like Dr. Kabulo's background, so I'm thinking about possibility to be there. Anyway, thank you so much for all of you, and we will see each other soon in live.
Oh, thanks so much. So maybe just one word from Ashish and Abdur, please.
Thank you so much,
Ashish?
Professor Kato.
Yeah.
Thank you so much, Professor Kato. I mean, this was great, and as you have always done, you have brought together experts from everywhere, including the YNS surgeons. I think it's a great opportunity. I wish when I was doing residency, I had access to these webinars and these teaching sessions. It's an amazing opportunity. Thank you so much for organizing this.
Thank you very much. So recently, the endovascular is very, very much high invading for the open surgery. So the endovascular, we don't see the brain. Maybe we don't see the aneurysm itself. But today, the very tiny MC aneurysm has bled during the procedure. So I think that then it has a very huge clot in the brain. So now we will have an emergency operation from now. So anyway, I think very less invasive treatment, the endovascular treatment, but we should be very careful sometimes.
I actually showed Professor Kato a few very, very small aneurysms, and you have to be very, very, very extremely careful. Again, MCA, I do not attempt. We have made sure that MCA, we don't go if there's a small aneurysm or if there is a complex aneurysm with a branch coming from the neck or the dome. That's out of our indication. If I try to do it, my fellow friend will be like, why are you doing this? So we have this kind of I'll say a moralistic attitude towards the indications. And when you know that you are fellows watching you, your colleagues watching you, you indicate and you make sure that you always achieve the right balance. So all the small aneurysms which I showed were mainly in the ACOM, because they were still a small neck. And as I said, like we have been very, very careful, and it comes with practice, like can have problems. As you said, now you're going for surgery. So
thank you very much. So Dr. Abdur, thank you very much for your valuable comment.
Yes, I am in India for Meningioma Society meeting, but I didn't want to miss this opportunity, and it is an honor to be among with you. Thanks for your invitation again. I learned a lot from all mentors. Thank you.
Thank you so much. So, Adi?
Yeah, I think this is
the end. Sorry, Sachin. Either Sachin and Andre.
Sachin left, but Professor Andrei Dubova is here. So
thank you, Professor. Thank you, Professor Kato, to this great opportunity to be a part of ACNS, a part of worldwide neurosurgery, and for opportunity to see my friends. And thank you so much for teaching.
Okay. Thank you. See you soon. Yes. Sachin?
Hello, am I audible?
Hey, we hear you, Sachin, we hear you.
Hi, am I audible?
Yes, you are. You can.
Yeah, so I'm sorry, disconnected and then I went to the attendees. So, but I was listening. So, the outset, first of all, thank you, Professor Yoko Kato, Professor Ibrahim, and Kubaile Tango for having this collaboration, tripartite collaboration. I think it was a wonderful idea, and many young neurosurgeons benefited from this. And I think we should continue this webinar series maybe every 6 months, maybe every 6 months we can have this kind of collaboration and webinar.
はい。林さん、ちょっと待ってくださいね。
Okay, thank you everybody. If there's somebody wanna say something, yes, this is the chance. If not, see you probably after the new year. There we will have another very interesting gas countries, probably for, should we say, Professor Kato? Probably from South America and Middle East. So see you guys in January. Thank you. Have a nice weekend.
Thank you. Bye.
Thank you. Bye-bye.